Good morning, everyone. So a pleasant morning to our distinguished guests, esteemed partners, colleagues, and friends joining us on site here at Marco Polo Ortigas, Manila, and those watching our Facebook live stream. On behalf of the Philippine Institute for Development Studies, a very warm welcome to UHC in Numbers, a forum on the Philippines' progress in universal healthcare. I am Chanel Mirafuentes, your Master of Ceremonies. Today, we gather to take a closer look at where we stand in making quality, accessible, and affordable healthcare a reality for all Filipinos. This forum brings together experts, policymakers, and stakeholders to break down the data, discuss key milestones, and highlight the challenges and opportunities ahead as we move toward full implementation of universal healthcare. We're glad to have you with us as we dive into the numbers, insights, and evidence that will help shape better policies and a healthier future for our country. We encourage you to join the conversation and be heard online. Just don't forget to use our hashtags, hashtag PIDS Public Forum, hashtag UHC in Numbers, and hashtag Health for All. I'd also like to remind everyone to accomplish and return the feedback survey included in your kits. Kindly make sure to submit it to our Secretariat booth outside before you leave. Thank you. So to formally start the event, let us welcome the President of the Philippine Institute for Development Studies, Dr. Philip Arnold Tuaño, for his opening remarks. Let's give him a warm round of applause.
Secretary Herbosa of the Department of Health. I think he's speaking via video in a while. Dr. Edwin Mercado, the President and CEO of the Philippine Health Insurance Corporation. Our leaders in government, represented by Director Joanna Banson of the Health Human Resource Development Bureau of DOH. Director Marwin Bello of the Bureau of Local Health Systems Development, also of the DOH. Dr. Manleta Irit, former Secretary of Health. Dr. Maria Rosario Vergere, former OIC Secretary of Health. The Public-Private Partnership Center of the Philippines, led by Executive Director Maria Cynthia Hernandez. I'm sure if she's ready around. The Senate Economic Planning Office, led by Executive Director Merwin Salazar, and representatives of the Office of Senator Pia Cayetano. The heads and executives of major health providers, health professional societies, hospital groups, patient groups, particularly Dr. Gerardo Legaspi, Director of the Philippine General Hospital, Director Evelyn Victoria Reside, the Medical Center Chief of the Quirino Memorial Medical Center, Dr. Sekuin, Director of the Asia Learning Institute, and Dr. Michael Campuet, President of the Philippine Society for Public Health Physicians. The city health officers and representatives from LGUs in the National Capital Region, members of international organizations and NGOs, particularly Dr. Yuli Park of the World Health Organization, and Mr. Ken Abante, President of the WeSolve Foundation. Friends in media, magandang umaga sa ating lahat. On behalf of the Philippine Institute for Development Studies, it is my great pleasure to welcome you to this full-day forum on entitled Philippine Progress in Universal Healthcare. Today's event is an important opportunity for stakeholders to reflect on our progress and challenges moving towards universal healthcare. When the UHC Act was enacted in 2019, it marked one of the most ambitious public policy commitments of our time. Natiyakin ng lahat ng Pilipino, anuman ang kanyang katayuan sa buhay, ay may pagkakataon at katayuang makamit ang dekalidad at abot-kayang serbisyong pangkalusugan. Several years later, a very important question now confronts us all. Nasaan na tayo sa UHC? This forum is a contribution in answering the question with evidence, clarity, and honesty. Over the past several years, since the PIDS Health Economics and Finance Program, headed by our Senior Research Fellow, Dr. Ulep, in close partnership with the Department of Health and PhilHealth, has assembled and analyzed some of the country's most comprehensive data sets from population surveys to social health insurance schemes and facility-level information. These data sets give us an unprecedented view of the health system and country's journey towards UHC. Today, we are presenting several studies undertaken by the program's research experts, flowing from these national representative surveys and large administrative data sets that aim to provide clear insights into the performance of our health system and the challenges that continue to hinder the full realization of UHC. The session this morning focuses on provider payment reforms, a foundational element of UHC. The UHC envisions a shift towards more transparent, equitable, and performance-oriented payment systems. We will hear evidence on how current payment systems function, what gaps persist, and how the designing provider payment measures can shape the quality and efficiency of care across the country. Provider payment is not merely an administrative concern, but it is a reform that goes to the heart of how healthcare is delivered and how providers behave. In the afternoon, we will turn our attention to presentations related to the building blocks of the UHC, including health financing, where stronger efforts for consolidation are necessary to strengthen efficiency, health infrastructure and capital investments, including the performance across planning, budgeting, and implementation, health information systems, which show that reforms for stronger digitalization and interoperability are needed, and the health workforce, the backbone of the system, where issues of compensation, distribution, and welfare are central to achieving reforms. Across all these studies, our message becomes clear: achieving UHC cannot be done in isolation, not by researchers alone, not by government alone, not by providers alone. UHC demands sustained collaboration among policy-making and implementing agencies, healthcare professionals, research institutions, development partners, and more importantly, the communities that which we serve. PHEFP, the Health Economics and Financing Program, intends to foster these collaborations by providing research that does not sit in a drawer, but instead guides real decisions that shape real outcomes for real people. We thank everyone who are here, researchers, policymakers, advocates, and practitioners, the people who collectively shape the future of the UHC. The evidence provided would only be as powerful as the decisions and partnerships it informs. We hope that today's discussions will further bridge research and policy, continue collaborations, and contribute to reforms that accelerate our progress toward a more equitable and resilient health system. Allow me to thank our partners in government, the Department of Health and PhilHealth, and all our resource persons and panelists, many of whom have long been champions of UHC. I also wish to acknowledge our PIDS-HEFP research team for their dedication in generating timely and high-quality evidence that will hopefully help guide the next phase of UHC implementation. As a national policy research institution, PIDS reaffirms its commitment to continuing generating, improving, and sharing evidence that will help guide and support meaningful reforms in the health sector. We look forward to working closely with all of you as we continue our efforts to make universal healthcare a lived reality for every Filipino. Maraming salamat, and I wish all a productive and enlightening forum today.
Thank you very much, Dr. Tuaño, for grounding today's forum on the importance of research and evidence in driving effective health reforms. His message reinforces the need for persistent collaboration among institutions and stakeholders to make UHC truly transformative. Now, to provide us with a message of support, let us turn our attention to the screens as we watch the message of the Secretary of the Department of Health, Dr. Teodoro Herbosa. Let's give him a warm round of applause.
Distinguished guests, development partners, stakeholders, panelists, legislators, and colleagues, a pleasant day to all. Let me begin by thanking the Philippine Institute for Development Studies through its Health Economics and Finance program for organizing this forum and for producing evidence that deepens our understanding of the country's progress towards UHC. The studies to be presented and discussed today provide important insights into how our health system is performing, what is working, and where we must focus our efforts. 2 decades ago, the world dared to imagine what once seemed unattainable, a horizon where health is universal. In 2005, the World Health Assembly adopted Resolution WHA 58.33, urging nations to transition towards universal coverage, anchored on sustainable financing and risk protection. Since then, UHC has become both a global aspiration and a shared responsibility among all member states. The Philippines answered this call with resolve and conviction, from early health sector reforms to the passage of the Universal Healthcare Act of 2019. We etched into law a declaration of hope that from the farthest mountain barangay to the heart of our bustling cities, the right to health and care shall know no boundaries. The UHC Act was designed with both pragmatism and foresight. It recognizes the principle of progressive realization, clearly delineates the roles of national and local governments, and the most critical, it prioritizes the reorientation of our entire health system towards primary care. This aligns with the DOH 8-point action agenda, where primary care and strengthening local health systems are at the very foundation. Since 2019, we have achieved significant milestones, but the work is far from over. We are working relentlessly with our local government units to build integrated provincial, citywide health systems. This is the structural backbone of UHC, ensuring coordinated, seamless care from the community health center to the provincial hospital. We have expanded PhilHealth coverage and rolled our targeted benefit packages that prioritize prevention and primary care, like the Yakap and Gamot packages. More recently, the implementation of zero-balance billing for basic accommodation in Department of Health hospitals, ensuring that no patient pays out of pocket for basic accommodation in these hospitals. Finally, none of this is possible without our dedicated nurses, doctors, midwives, and community health workers. We must continue to value them, invest in them, and empower them as the true frontliners of UHC. This forum comes at a crucial moment for the Department of Health and PhilHealth as we reassess and review the implementation of UHC supported by the Healthcare Financing Strategy of the Philippines 2023 to 2028, which is our strategic roadmap to strengthen financial risk protection, improve efficiency in health spending, and support the expansion of primary care, health facilities, and the health workforce, translate into accessible, high-quality services for all Filipinos. This forum also reinforces our shared commitment to evidence-based policymaking and intersectoral collaboration. The insights we gain will help us better align national policy with the realities on the ground, making our interventions more impactful. Let us continue to work together, academics, policymakers, implementers, and civil society, to build a stronger, more resilient, and more equitable health system for every Filipino. Dahil sa bagong Pilipinas, bawat buhay mahalaga. Maraming salamat po.
Though he may not be physically present with us today, we would like to give our utmost thanks to Secretary Herbosa for his inspiring message and for reaffirming the national commitment to delivering accessible and equitable healthcare for all Filipinos. Secretary Herbosa, your leadership is vital in pushing forward the reforms that will strengthen system resilience and improve service delivery nationwide. Now, our next speaker has had a professionally fulfilling career as both a clinician and as a healthcare system executive. He now aspires to share his expertise to advance the UHC reforms through PhilHealth's latest vision plan. Let's extend our gratitude to the President and Chief Executive Officer of the Philippine Health Insurance Corporation, Dr. Edwin Mercado, for his message of support.
A warm good morning to all of us. First of all, I'd like to thank the Philippine Institute for Developmental Study for giving me this opportunity to somehow give you some updates, especially as regards our research agenda. First of all, I'd like to acknowledge my boss, Secretary Herbosa, who unfortunately is not here, but gave a very strong message in support of the initiative to make UHC fulfillment. Dr. Yuli Park, lead of the WHO Philippine Health System Strengthening Team. Dr. Manuel Dairit, my mentor, former Secretary of Health and incumbent Swedish Family Foundation Chairperson. Dr. Maria Rosario Singh, our former OIC Secretary of Health. Dr. Philip Arnold Tuaño, President of the Philippine Institute of Developmental Study. Dr. Valerie Gilbert Ulep, the Senior Research Fellow and Program Director of the PIDS-HEFP Economics and Finance Program. Our hospital officers, Dr. Gab Legaspi, my dear classmate, Batch 87, UP College of Medicine, Director of the Philippine General Hospital. Dr. Jose Acuin, Director of the Asian Learning Institute of the Asian Hospital and Medical Center. Dr. Evelyn Victoria Reside, Medical Center Chief of the Quirino Memorial Medical Center. Civil society representatives, of course, there's Dr. Med Campuet, President of the Philippine Society of Health Physicians, Mr. Kenneth Abante, President of WeServe Foundation, and I can see Dr. Tessa Tan Torres, my dear kababayan and friend. Technical team members of the PIDS-HEFP, dedicated researchers, organizers, colleagues, guests, and friends. I distinctly remember when I was here also during the launch of the health economics and the finance program of the PIDS. And I was then just 1 month into my term as president of PhilHealth. So maybe now on my 9th month, I can give a more honest view of what we need in terms of our research agenda. Of course, evidence-based data is very important, and because that's our mantra. Something that is not supported by number does not exist. So I'm very happy with the PIDS that we already approved a grant, and the board already approved a 3-year multi-year contract. And I think by December, we will already assign 10 fellows of the PIDS in the PHIC, in the PhilHealth, where we will be directing towards a lot of data-driven analysis. There's tons of data in PhilHealth, but unfortunately, nobody, except for the PIDS and the Task Force Informatics has been given. But these are mostly static data. We want to do more in-depth analysis of our data. Just yesterday, we had a meeting with the Institute of Medical Health and Evaluation, HM, to also analyze our data. And we're going towards more data-driven quality assessment and evaluation of our providers. So of course, I'd like also to mention our engagement with the multilateral agencies. ADB has been very supportive of our initiatives. We are meeting this afternoon with the Global Fund. who's also very interested to support our initiative, especially for YAKAP, as we integrate all the HIV, TB, and malaria initiatives into YAKAP. The World Bank, of course, is here, and all the hospital and doctor groups we've been continuously engaging, especially the PHA, the PHAPI, the PMA, different subspecialty organizations, and the CSOs. So, what are we doing now? Nasaan na tayo sa UHC? It's not moving forward. Ano yung pinindot? Ito, di ba? Okay. So we defined several priorities. Next slide, please. And one is our pivot to primary care. According to PIDS study, 40%, almost 40% of hospitalizations are ambulatory case sensitive sensitive, which means if we do honest to goodness primary care, that's going to be an economic burden that will be offset. If we're looking at expending 25% of total PHIC budget into primary care by 2028. So my simple mathematics is if I save 40% and I spend 25%, I have a net income or a net positive of positive 15%. So that's the end objective of YAKAP. And YAKAP is now focusing on outpatient medicine because outpatient medicine constitutes 40% of the out-of-pocket spending of Filipinos. Our objective is to lower down the out-of-pocket spending of Filipinos from 44.7, the latest figures, it's nearing 41%. And this year, with our 50% across the board increase in our ACR, most probably it will further go down. And our objective is lower it down to almost 25 to 30%. So focusing on the primary care and also cancer screening, which accounts for the biggest portion of our inpatient expenditure, the most catastrophic cases are mostly cancer cases, would probably lead to all these efficiencies and decrease in our inpatient expenditures. The remaining, if you may say, in the continuity of chain is the specialist outpatient program. So that's what we are focusing on, probably be developing this year. And that's where we need help from the PIDS on really seeing how the best payment model would be for specialty consults on an outpatient basis. Because we're already covering the ER, even the outpatient ER. And once you get admitted, we already covered the inpatient, especially for the catastrophic diseases through the Z packages. So these are more or less continuity of care. The next would also be our study on rehabilitative and palliative care, especially for end-of-life care, which we are also looking at developing in the next year. Next slide. So next slide, please. Kasi ayaw mag-move. There. So a lot of issues are hounding YAKAP, and these are just birth pains because we still believe the endpoint justifies our shift and pivot to primary care. One of which is the different stages that you have to go through. And for exigency, we already defined the definition and the nomenclature. Everybody thought that automatically, because we are already PhilHealth members, we are automatically YAKAP accredited. So to differentiate, registration is when you get your PhilHealth ID number. Basically, it's a way of assuring your identity. And with that, we're already putting facial recognition as a way to verify because our membership data is now interconnected with the PSA data. So we have facial recognition to really determine the identity of the patient. So upon registration, you go to the assignment. The assignment is when you choose your YAKAP provider. So that can be through several portals. It could be through the eGov app. It could be through your membership portal. It could be you go directly to the provider and asking the provider to register you. And there are several, just so because not all individuals have access to internet and to the technology, we even go to different places, especially the GIDAs, through our caravans. And once you get your assignment, then you do your FPE conduct. The FPE is the first patient encounter, which supposedly you do a thorough evaluation of the potential risk of a patient. But we're trying to look if we can veer away from FPE, because this is not for us a really efficient way of really assessing a patient. And also in terms of computing the payment, we don't think it is the right denominator or the right, because under formula for YACAP, the first payment is based on on the FPE, and the subsequent output-based payment is still based on FPE, which we thought should be in terms of the assigned or your population expected, and it is upon the provider now to go to the community and really look for diseases or all these chronic diseases instead of waiting for the patient to go to the clinic. And the last is empanelment. So once you get your assignment and you get your FPE, you have to sign a patient bill of right type of document. We call it the YACAP empanelment slip, to ensure that the provider and the patient knows what their individual responsibilities are. Next. So because of all these new things, we're doing our phase implementation of the YACAP, especially as regards the gamot, into what we call matalinong pagpapatupad or phased implementation. So we are now doing a lot of our reorientation of the provider through our SHIA, the Social Health Insurance Academy. We develop modules, and that is part of the provider readiness. If you get certification from the DOH, if you went through our SHIA module and you pass the pre and most especially the post tests, and then we do inspect your facilities and you're ready, you have all the requisite infrastructure like your internet connection and all the different apps that are in your computer, then we go to linking you to the pharmacy. Now we are also readying a module for pharmacists, because the pharmacists are the first one who have also a visibility of all your utilization. For now, we don't have, our app do not have yet the capacity for the patient to have visibility of their current utilization pattern, but the pharmacists do. And we're now asking the pharmacy, I even talked to the Pharmacy Association, that they are a vital part of the full continuity of care in primary care. And to make sure that the medicines are appropriate, that the quality are appropriate, and that the patients are really instructed on how to continue taking their medicines to ensure that their health is taken care of. The third phase is already targeted beneficiary engagement, where we will open now the app such that the provider now can input the prescription into the YACAP portal. Unfortunately, because it's end of year, we've been finding reports that people are already overutilizing their 20,000 limit because they thought that it's going to be end of year, sayang. Even if us telling them, it's a recurring thing, it zeroes out by midnight, and then it reappears 12:01 with the new 20,000. So we've been seeing patients who were given 4 different antibiotics for one infectious disease. We've been seeing people with one diagnosis for hypertension, but they have 4 different formulation of the same generic or molecular type just so they can maximize the 20,000. So those are things that we're plugging, and precisely why we're doing this phased implementation. Next. The other thing is we're already finalizing our evidence benefit expansion plan. Again, this is with the PIDS, where we identified our priority A. We're doing work now with the subspecialty societies because there are certain disease types that are lumped together. For example, trauma. So we need to identify which are the trauma priorities. We already have the C package for orthopedics. I just announced. I'm working closely with the Philippine Orthopedic Association in already rolling it out. We have several government DOH retained hospitals who's offering it now. But we're also looking at other trauma-related injuries, for example. Another area where we want more definitiveness is like congenital abnormalities. So we're looking at now at the next 15, maybe 20 diseases where we will be doing RZ benefit packages for next year. But upfront, we're reviewing leptospirosis. We're reviewing maternal care because maternal care is in our top 10 disease entity or reimbursement cases. But the number one reimbursement cases is dialysis. So we're also reviewing the indication on why dialysis utilization is so much and whether we need to do something in YACAP to prevent the progression to dialysis more than funding the dialysis. So those are things that we need help on, and hopefully the research agenda will be defined. Next. So what has been the impact so far? Next. So the impact is, syempre, dadami yung aming benefit expense. So we've been spending a lot, 217.93 billion in fact, compared to 112.23 billion last year. So that's a hefty 94.18% increase. But are we spending the money in the right diseases? That's the question that always comes into my mind. And are the systems in place to ensure that it is not, overly used? So those are things that we are focusing right now in terms of putting what we call gates. The gates are ways to preemptively already pick up once the cases that are most probably not indicated or cases that may not fall within the standard of care. So we're looking at, for example, our pre-authorization. Right now, most of the pre-authorizations are for Z packages. But we already talked with one HMO if we can do pre-authorization for our outpatient cancer screening. And they gladly said, yes, we will help you, even if it's a grant only for 1 year. But at least it will give us now data. Because right now, we still don't have the check and balance system for our outpatient cancer screening. So that's another thing we're setting up before we fully launch YACAP. The other thing is our shift to DRG, which is another area that we're doing work with the PIDS. As I mentioned earlier, the IHME was with us yesterday and also would want to work with us, especially as regards groupings for our DRG algorithms. Because I think they already have some data as it pertains to some other similarly situated countries. Next. So very important, as I said, is making every peso count. That's why, next, these are our, next slide, these are our main strategic shift. From ACR-based claims, we're looking at shifting to a DRG-based prospective global payment. So as Dr. Val said, we need about 4 to 5 million claims. We already are engaging the PHA, the PHAPI, to really enjoin and also push their doctors to do DRG coding. The most difficult parts are the doctors. They always want, bahala na yung clerk. And then if the clerk makes a mistake, they say, kasalanan ng clerk yan. Eh. So we're already engaging them to do it in the guise that if you don't participate and you don't put all your comorbidities, then we cannot come up with a really honest to goodness DRG multiplier and system. So I think once it hits their pocket, they become more responsive. But apart from that, we're looking at ways to incentivize those hospitals that are compliant. We say, once you're compliant with our rules and we can see your metrics and your denial rate is low, we will expedite your payment. From before we came in, it's about 40 to 60 days payment. We have brought it down to 18 to 22 days. And now we're looking at for low hospitals that are compliant with our rules to lower it down to 7 days. So that's an incentive enough for them to also participate in the DRG. Number 2 is accreditation. Now it's more checklist-driven accreditation. But we want it to be a more strategic contracting accreditation, where we would be looking at hospitals. As I said, we have dossier on each hospital in terms of their quality metrics, and say, can we engage you on Z package, but with a particular fixed cost or predictable co-payment. But if you give us and provide us this quality care, then there's a carrot for you. And that is what we need help on in determining what the carrots could be. The initial carrot is just payment in 7 days, masaya na sila. But if there are economic carrots that can be implemented, then the more. Especially for the 10% NBB for private hospitals, they're willing to already implement next year because the support value of PhilHealth has gone up significantly. But they said, can we really keep it to 10%? And forgo the IRR that stipulates if the patient still decide to get a ward accommodation, but it's full, then you're compelled to give them the next higher accommodation. And if they say, if you can promise us that, then we can comply. On the other hand, I said, if you comply and you give more, and we see that the case mix is better, I give you an additional X%. Wouldn't that be better? And I think they're open. That's why we are creating a technical working group with the PHAPI on drafting all these carrots. The third is from output-based performance to outcome-based. So that's the same way as the carrots that I mentioned earlier. But even for RIACAP, for example, we need a very robust EMR system. That's why we're talking earlier with the World Bank on how we can work together in providing a very standard EMR or even grants. Because 70% of EMRs today are still on our e-consulta portal of the PhilHealth, which is actually a transitory EMR. It's not a long-term EMR that would generate the data we need for analysis. Number 4 is one-size-fits-all benefit design to a more market-based responsive benefit design, especially for provider distribution like the GIDAs. And that's where the DRG also comes in, because we can have multipliers in the DRGs to preferentially give additional compensation for doctors that are providing care in a GIDA area, even for hospitals that are, we know that the cost would be higher because it's an academic institution, it's a research institution, etc., etc. So from heavy manpower-driven post-audit to more automated red flagging of rules deviation and standards of care, we're piloting with, again, an ADB grant on really determining if there is matching of diagnosis and the drugs in YACAP. Also, we are looking at putting a pre-validation in our e-claim system where AI somehow will already flag deficient documents so that it does not go through the whole process. And the fourth is from request-driven extraction to real-time business intelligence dashboards. And this is also where we want help, especially from the economic team, because DICT is working closely with us. We're the priority agency upon the orders of our president. And we're hoping that by 2026 and 2027, we will be fully automated, that we will have a war room where we can, in real time, say, how is PGH's performance? We'll click average hospital stay, denial rate, what is your time from door to PTC, to giving your thrombolysis to giving your, doing your cardiac angiogram. All those stages of the disease continuum can easily be tracked down to the level of each hospital provider. Even assessing the success rates of all these interventions. So these are just some of the view or of the areas that we want to focus in terms of reform and where we want and we need help of the PIDS. This is all along our intent next to have a PhilHealth that is fast, fair, and trustworthy. Thank you very much po, and looking forward to engaging further with the PIDS.
Thank you very much, Dr. Mercado, for your comprehensive discussion on the ongoing improvements in PhilHealth's programs and processes. And in the true spirit of our partnership, may our agencies keep seeing each other again in our respective endeavors as we embark on this critical journey to realizing timely, fair, and reliable care for all Filipinos. Now, to introduce today's sessions, our first presenter is a senior research fellow at PIDS and the program director of the Health Economics and Finance program. He has authored discussion papers, book chapters, and journal manuscripts on health financing, health policy, and nutrition. He has also provided technical assistance to governments and international partners alike. Let us please welcome to the stage Dr. Valerie Gilbert Ulep.
Hello. Good morning. So thank you again for joining us in this forum. So what is this forum all about? No? So we believe that as the country's socioeconomic think tank, we should help start a discussion on where we stand on one of the most important entitlements of Filipinos, which is the promise of universal healthcare. So, bakit siya tinawag na UHC in numbers? So, we conceptualize this because we have realized that health data in this country, when we're doing a lot of this research, is extremely hard to obtain. No? It's extremely difficult to obtain. It's not the data doesn't exist, it's that they are hard to access, hard to process, and scattered across multiple sources. So for the longest time, the approach has been to gather whatever data we can from different systems, just to piece together a comprehensive picture of how our health system is actually performing. So okay, so UHC number asks a simple but important question. What do the numbers really say? Are we making progress in health outcomes, financial risk protection, and overall health system performance? To answer this, we feature a set of the data-driven research studies that dig into the core inputs of the health system. These are your finances, your infrastructure and capital investments, your health human resources, and your digital investments, right? So these inputs are what ultimately shape our progress towards UHC. Next slide. Okay, next slide. Click. So I always begin with health spending, no? Because it's the clearest reflection of a country's priorities. And it sets the stage for what we accomplish in the UHC reform. No? So in this figure, we see a very striking pattern. Over the past decade, health spending has more than doubled, even adjusting for inflation and population growth. So around 11% annual growth, higher than your GDP. The yellow bar shows the years after the UHC Act, which also coincides with the pandemic, and you've seen rapid increase in public spending during that period. Again, both of these important aspects, the pandemic and the institutionalization of UHC, improve increase public or health spending over the last 10 years. So by 2024, the country, as a country, we're spending around 12,000 pesos per Filipino, and the total health spending has reached about 5% of GDP, finally putting us at a par with countries at a similar income level. In 2021, the health expenditure already reached 1.5 trillion. In 2021, it was 1.2 trillion, and in 2024, it's now around 1.5 trillion. So that's how big the health sector is. Next slide. Next slide. Okay. So when we examine what has driven the increase in health spending over the past decade, one pattern stands out. Most of this growth in health spending is actually coming from government spending, meaning central, PhilHealth, and local governments. So in 2024, out-of-pocket spending, however, remains at 43%, but government financing through DOH, national governments, PhilHealth, local governments, and other agencies of the national government now makes up around 44% of the total health spending. So on the right, so we try to index it to 100%, to 100, government spending has increased by almost 2.6 times since 2014, no? So even adjusting for population growth and inflation. This shows that the expansion of the health expenditure in recent years has been largely driven by the government spending. Next slide. So when we talk about government spending on health, it is important to remember that it comes from three sources that I've mentioned: central government, local government, and PhilHealth. While total spending has grown significantly over the past decade, these three sources have grown in different ways and at different speed. And we argue that this trajectory of these three major public spending will have a dramatic impact on how we deliver care and whether we achieve the goals of UHC. So later this afternoon, one of our presentation is the multi-payer system in a fragmented regime. We'll talk about the tensions of these three major sources of financing, public financing. Okay. Next slide. Okay, sorry for this small figure. But as I've said, there is an increasing government spending, no? So I want to show you this figure because this compares how much government spends on health relative to the size of the economy, right? So every brown dot is a country, no? And the Philippines is shown in red. So these are your government spending on health in the last 3 years, 2015, 2019, and 2013, right? So the key takeaway here is very simple, that the Philippines is now spending as much on health as other countries with similar income levels, in this case, GDP per capita. So as our income has increased, our government health spending has also increased, and it's now sitting right on the trend line. So hindi tayo masama when it comes to government spending. Actually, we're above compared to other regions or when we relate it to the income of other countries, no? So why is this very important, at least from our perspective? Because the y-axis, so the y-axis is the government spending as a share of GDP. It is one of the most important measures of a country's commitment to health. It shows not just how big the economy is, but how much of that national income we choose to invest in keeping people healthy. Now, the next slide. I want to juxtapose the next slide with this one, the previous slide with this one. So the previous slide is the government spending. Now, here is an important point. Even though that the government spending on health has grown, it has not yet translated into big reduction in out-of-pocket spending. So this figure shows the relationship across countries. So the horizontal is your government spending as a share of GDP, right? And the vertical axis is your out-of-pocket as a share of total health expenditure. So in general, countries that spend more on public or more on on health from public sources see lower out-of-pocket, which is what we want because it protects the families and household from financial hardship. But if we examine this, this figure, highlighted in red in 2015 and 2023, even as our government spending increased, our out-of-pocket has remained high, clustering around countries that spend much less publicly. So if you're above the green line, then you're spending, the share of out-of-pocket is high. So my point is, you're spending, the government is spending more relative to its economy, but we're still seeing high share of out-of-pocket. So there is somehow a disconnect there. Next slide. So next slide. Next slide. So earlier, we showed that government spending on health as a share of gross domestic product is already on par with countries at a similar income level. So we're okay with that. So relative to our economy, we're investing at a comparable level. But this slide uses a different measure, government spending as a share of your total health spending. Here, the Philippines is, our next slide, is around 44%. So you have seen increasing over the years. But if you look at the share of government spending, central, local government, and PhilHealth, around 44%. But if we transition to be an upper middle income country, we're still far from that. Because you look at the average for upper middle income country, it's 60%. If you look at high income country, it's 70%. So we're still below the low middle income country average. So that's the point of this. The share of government spending to the total health spending is relatively low because our out-of-pocket is still very high. Okay, I want to show you this next slide. I always compare the Philippines with Indonesia because we have the same history of health financing reform. In 2015, they started to amalgamate most of this multiple health insurance scheme, I think in 2015 or 2016. So to appreciate the decline of out-of-pocket in the midst of financing reform, I'm going to show this figure. So the slide compares the Philippines and Indonesia, a country that implemented major health financing reform, I think in 2016. So on the left is for the Philippines. You see that the government health spending as a share of gross domestic product is increasing, right? But our out-of-pocket spending has declined only very modestly, right? Yung green is your out-of-pocket, right? But when you look at Indonesia, their out-of-pocket really declined as they invest more. So mas may value yung pera nila compared to the Philippines, at least in the reduction of out-of-pocket. But obviously, there are so many problems in Indonesia, but looking objectively at the reduction in out-of-pocket, they are actually more successful as they invest more. So I think that's one of the takeaway of this slide. Next. So, okay, so we've seen, just to keep emphasizing, we've seen that the government health spending has increased significantly over the past decade. So I think we agree on that. But the real question is, I show some numbers later on, is that are these investments translating into better health outcomes or stronger financial protection, which Dr. Edwin was referring to a while ago. So, and these two vision, improvement in outcomes and improvement in financial protection, is envisioned in the UHC Act. So this is where the rest of our analysis focus on. Not just how much we spend, but whether that spending or the public spending is improving health outcomes and financial protection. Next slide. I'll start with infant mortality as we dissect. So let's look at infant mortality because this is one of the classic sensitive measure of health, or health system performance. So it captures not only medical care, but also nutrition, maternal health, and living condition. So the red line shows the Philippines, the Philippines over time, So for every 1,000 babies born alive, about 22 die before their first birthday. What is really concerning over the years is that our progress has been much, much lower, and you will see that later, than that compared to our ASEAN neighbors. So the global average, you can see, was higher in 2000, right? Now, they're actually lower than the Philippine average. That's also true for upper middle income country. We are transitioning to be an upper middle income country, but our infant mortality rate is comparable to the poorest regions in the world, right? Then that's also true for ASEAN. So that's the idea that I want to pursue. No. Next slide. Sorry again for the small figure, but the idea here is that the Philippines is really a microcosm of like a global health inequities. No, so there are regions in the country with an infant mortality rate similar to emerging economies like Mexico, etc. Then there are also countries na mababa talaga, no. And that's also true when you look at socioeconomic status. No, you don't see this in many countries in the region with this great socioeconomic gradient. The infant mortality of the poorest is 26. The infant mortality rate of the richest is 6. Next slide. Okay, sorry again for this, but this slide tries to answer a simple but uncomfortable question. Has our big increases in public spending actually improved basic health outcomes? So on the left, we look at infant mortality, and the right is your life expectancy. So on the left, the horizontal axis shows how much spending on health per person grew between 2015 and 2023. So the horizontal is your public spending, adjusted for inflation and population growth, and your vertical axis is growth in IMR. What you can see here is very simple. The Philippines is one of the biggest public spending on average in the last 10 years, right? But the growth or the decline in IMR is 0. So what you can see in the countries in the region like Thailand, Cambodia, Vietnam, they've spent, the public spending for health is, increase in the last 10 years, then they also observe large decline in IMR, right? So that's the biggest question, like, are the public spending translating to better outcomes? And the next one is the life expectancy. It's a very simple measure of health, right? And we see the same. We're the biggest spender, but the changes in life expectancy is also not observed, no. Or improvement, I should say, no. Okay, next slide. So we also try to examine person-level mortality data from PSA. We try to analyze the trends in avoidable mortality, no? So that is the deaths that are considered treatable and preventable with timely and effective healthcare. So in this analysis, we use the 10-year data from PSA, and we use the framework of OECD, no? So what we found is concerning that for nearly 2 decades, about 35% of all deaths in the Philippines are avoidable, meaning it could be treatable or it could be preventable, no? And this share has barely changed in the last 10 years, no? So the age-sex adjusted avoidable mortality rate shows that only very slow decline with no meaningful improvement in recent years. So this tells us that despite the rising health spending, we reflect if this really translating into improvement, at least for in this case, is preventable mortality. No? Next slide. This one is just data again from multiple sources. The left is the share of premature mortality due to NCD and your GNI per capita. Ang ibig sabihin nito is that there are more premature death, no? Or the share of premature death is high. And what you can see here is you compare to the region, tayo yung highest, no? So madaming namamatay sa NCD prematurely. And when you look at the PSA data, their death level data, you can see that there is huge variation. There is around 70, the share of NCD death in Soxar or in Davao is around 70%, which is comparable to a lot of relatively poor countries. Then in other parts is like 50%. No, so again, huge variation when it comes to the share of premature mortality as a share. No, next slide. Okay, this one is just, we just did an analysis of the catastrophic health spending. I know there is a new measure of catastrophic health spending in the Philippines, but in the last 10 years, we've seen a large decline in, a significant decline in catastrophic spending using the traditional measure, which is 10% of your income. But 2028, again, you see slight increase. No? So this is what we are seeing, at least using the traditional measure of catastrophic spending. So we're not seeing a decline, but like a plateauing or a slight increase. No? Next slide. Okay, now that we're discuss health outcomes, I want to examine this one or present this one, which is the UHC service coverage. No? So the UHC service coverage index measures how well the countries deliver essential, very essential services across maternal, child health, infectious diseases, and non-communicable diseases. So there's a scoring system up to, if I'm not mistaken, 100. No, the Philippines score 58, about 10 points below the global average of around 68, and behind many of our ASEAN neighbors. So across 3 domains, only modest improvement can be observed, for example, in infectious disease. No, next slide. Okay, there are many indicators in the UHS Service Delivery Index, but I want to zoom into a very important indicator, which is immunization, right? It's a very essential health service, no? So if you're failing in this service, then you need to question the whole capacity of the system. I think that's my argument, right? So I'm using here a global tracer indicator, which is DPT-3. So a core indicator of how well a health system delivers a routine primary care through immunization. So what we are seeing here is a worrying pattern, right? So number one is across, let's compare within the country, and you can see large variation. Like you will see vaccination rate of 95% in 2022, then 20%. I mean in 2022, and you see like 20 in some regions, right? So, but on average, you see a declining pattern, no, of immunization coverage rate. So you don't see this anymore in ASEAN, no. And what we are seeing is when we compare this, the last one, with other countries in the region, you see an interesting patterns, right? So we're lowest in the region, only next to Myanmar. But if you try to look again at examine again in some regions, there are some regions that are actually lower than fragile states, like Central African Republic, like Afghanistan. So I think there needs to be examined, why do we have this level of DPT-3 vaccination, right? So yeah, it's a huge variation, intra and inter variation. Next slide. Okay, another tracer indicators, because we cannot mention them, is this: a cervical cancer screening, a basic essential preventive service that pictures, and this figure is even more alarming. Only 1% of Filipino women aged 30 to 48 reported being screened in the past year. So that places us among the lowest in the region, comparable to countries with far fewer resources. So here at the subnational level, you see that variation again, but it's not big. Like NCR, only 4% of eligible women, in BARM less than 1%. So again, those are just the 2 tracer indicators that we can gather from the UHC service coverage indicator, just to kind of dissect and zoom into the issue. No? So next slide. So why are we seeing slow progress in outcomes and uneven service coverage? So in the next discussion, our research points to persistent issues in the core inputs of the health system, like your infrastructure, your delivery, your health human resources. No? So yeah, that would be the point of this session. So we'll look into these areas. Health Human Resources, presentation number 7. Service Delivery and Capital, presentation 3 and 5. Financing is on presentation 4. Health Information is presentation number 6. No? So next slide. So almost done. So this slide, I just want to summarize this. No? So this slide summarizes how, in my understanding of the political economy of health systems, so this is just a stylized depiction of priority focus of health countries. No? So if you look at the history of health reforms, many countries start with building access, like service availability coverage, nakatanggap ba ng, I don't know, immunization or not. Then as you move along with your income, then you start to think about bending the curve, right? And these reforms include improving efficiencies, like provider payment reforms, health technology assessment, consolidation of health technology assessment, consolidation of financing, et cetera, no? Then as you move further, then you see more policies in terms of quality of care, performance-based, readmission rates, et cetera. So those 3 waves, I would say that obviously we're still in this access, but as you move along with the income trajectory, we need to think about bending the curve, like improving efficiency, and whether our investments are really translating to outcomes, right? And lastly, one of the core reforms we are pushing, which I think Dr. Edwin mentioned a while ago, is shifting the way PhilHealth pay providers. So for many years, our payment system has been output-based. So we reimburse hospital based on volumes, right, number of visits, etc. But under the UHC Act, the direction is more towards outcome-based payment. So that's Section 19, right, if I'm not mistaken, such as DRG, global budget, then you do performance-based. So here, hospitals are rewarded for delivering better results, no? Not only outputs. So let's say fewer avoidable hospitalization, controlled chronic conditions, lower admission rates, and fewer hospital-acquired complications. So I think we need to start discussing this already. Not only, nakatanggap ba ng bakuna, but we need to start discussing these quality indicators, right? Because this will be a very important basis for performance-based payments or outcome-based payments. So in this forum, we try to kind of introduce that, given the data sets that we have. So in presentation 1 and 2, so we're going to discuss about DRG, global budget, and some examples of efficiency, equity, and quality care measures. It's not perfect because for decades, we are not suited to collect all this information, but we tried to collect it. So there are some of the results that some of the results will be showing later now. So yeah, so I tried to discuss or connect all these presentations together to have a more comprehensive picture of how we move forward with UHC. So I think that's my last slide. So thank you so much.
Thank you so much, Dr. Ulep, for your insightful introduction to today's session. Your overview provides the much needed context to allow our audience a greater appreciation and anticipation for our subsequent presentations. So without further ado, let's now introduce the first study, which will be discussed by a health policy and health financing consultant for the Philippine Institute for Development Studies. So as the policy lead at HEFP, she provides policy guidance for the Philippine Health Insurance Corporation's transition to a diagnosis-related groups and global budget payment system by developing frameworks, technical materials, and documentation to guide the DRG grouper, budget and payment calculations, monitoring and evaluation, readmissions monitoring, and health insurance fraud control. We warmly welcome Ms. Vanessa C. Van to the stage.
Morning, everyone. So I'm Vanessa, and today I'm going to be sharing with you a retrospective policy analysis of the all case rates or the ACR payment system from 2018 to 2023. So it's really been a long journey. You know, Dr. Edwin mentioned all of the reforms. Val was mentioning where we are headed in terms of provider payment reforms and health financing reforms. But I think it's also important to show where we were coming from, to explain and really highlight the need for such reforms, and to explain and juxtapose where we are now with where we started. So maybe to begin, we should ask the question, what is a PPM or a provider payment mechanism? So simply said, the PPM is just the system for paying for healthcare services. And the current PPM that we are operating under with PhilHealth is called the all case rates. And under the ACR, PhilHealth will pay providers according to what we call the case rates, which are just fixed flat payments for at most 2 medical procedures or diagnoses. But the thing I want to highlight is that your PPM will create certain incentives, or it sends certain signals about what is acceptable, what is rewarded, what is going to be paid for. In that way, the PPM is a very powerful policy lever that can transform how healthcare is accessed and provided. First of all, when we talk about health financing, we often talk about financial risk protection, right? We give the most focus to terms like OOP, FRP, total health expenditure. But at the same time, the PPM itself is a powerful tool that can bridge current health financing gaps with the UHC goals. So progress towards a more responsive, transparent, and fair PPM is actually measurable. And there is a need for us to do that measuring and do that analysis using national data sets like the claims data to systematically and empirically assess how PPM actually drives and leads to the financial risk protection measures that we see. In that way, we analyzed the ACR PPM data from 2018 to 2023 using 6 provider payment characteristics that can influence health facility behavior. And I just want to note that the data we had was only until 2023 at the time, so the current numbers might have changed. But what we want to highlight is that you can have these domains that you assess and measure. So sufficient payment rate just means that payments adequately covered the cost of delivering healthcare services. Timely payment rate adjustments mean that regular review of payment rates are there to assess their alignment with treatment costs, changes in technology, and market conditions, including things like inflation, as well as the budgetary constraints, and being able to adjust those rates as needed. Bundling refers to aggregating services and paying for them as a group or bundle, as opposed to individually billing and reimbursing each service. And performance monitoring is monitoring and feedback for the providers regarding their status and current performance. And that also includes systems that remunerates providers based on providing quality and efficient care. And if you are able to do 1 to 5, then you will most likely also have the timely payment schedule, which means that the period or the frequency of payments are predictable and timely for health facilities. So we were able to leverage comprehensive national data sets made possible through partnership with PhilHealth. And we would especially like to thank PhilHealth, especially President and Chief Executive Officer, Dr. Edwin Mercado, and the TFI or Task Force Informatics, because thanks to them, we were able to work with nearly 90 million PhilHealth e-claims data from 2018 to 2025, 2 million e-claims with eSOA, so the statements of account, from 2025 of May to October, and additional data sets like the list of accredited health facilities, healthcare professionals, consulta member registration, consulta first patient data encounter data set, and the PhilHealth RVS, ACR, and Z benefits list. And at the same time, we'd like to recognize the HEFP data team for expanding the data we have available, which you will see in the many presentations today, from DOH, from PSA, and also from the DOF, Bureau of Local Government and Finance. So let's talk about the findings. The story we often hear is that National Health Insurance Program doesn't really offer enough coverage. The story we hear is that PhilHealth is not enough. But really, to understand what works and doesn't, we need to analyze the ACR policy design and empirically assess the magnitude of its effects and share this information with our partners at PhilHealth so that they can in turn make the necessary program changes and operational changes to make a meaningful difference. So what did we find? In the past, we found that ACR currently has limited mechanisms to regularly update payment rates to reflect inflation, cost changes, or new technologies. So ACR payments had not been systematically updated since implementation in 2013, even for medical inflation. Of PhilHealth's 8,800 original case rates in use in 2021, a COA report from 2021 found that 99.9% had not been updated yet at the time. But medical cost inflation at the same time was outpacing headline inflation, with prices of hospital inpatient services increasing by an average of 3.4 every year from 2014 to 2023, leading to ACR's real peso value decreasing by over 40% in the past decade. And for example, in the analysis of our claims data, we found that before the ACR rate increase at the start of 2024, the case rate for NSD, or normal spontaneous delivery, was 6,500. But at the start of 2023, if you adjust for inflation, the real peso value was only 3,900. So in 2024, PhilHealth acknowledged this, and they were able to implement case rate rationalization and increase their case rates by 50%. But you can see that not being able to adjust on a regular basis is a major factor that drives low support value. As seen on this slide, mean hospital charges increased 51% from 2018 to 2023, while at the time, mean PhilHealth reimbursement remained steady at around 11,000 pesos. So with PhilHealth covering a decreasing share of healthcare expenses, patients are exposed to increased financial risk. So what you see here is the ratio of PhilHealth claims with hospital charges greater than the case rate amount. And what you can see is that from 2018 to 2023, the share of claims with actual charges exceeding the case rates increased to 98.8% in 2023. So it shows that ACR payments from 2018 to 2023 hadn't really kept up with the prices increasing for healthcare services. The second thing is that ACR provides limited differentiation in the services required to treat patients of varying clinical complexity. So under ACR, PhilHealth will pay for a bundle of up to 2 case rates per patient, regardless of the number of diagnoses or procedures that were performed during their stay. The first diagnosis or procedure is paid the full case rate, and then the second one is paid 50% of the case rate. Because of the flat case rates per disease or procedure, in effect, this limited bundling is left up to the provider's discretion. The provider has to choose which of the 2 diagnoses or procedures they should claim, often choosing the highest paying case rates. But this has a consequence because it penalizes patients at greater risk for severe illness. So what we did here was we took ACR e-claims data from 2018 to 2023, and we tried to group them in the DRG grouper that we have now. We see that support value declines as the case complexity increases. So for example, 2 patients, both of them diagnosed with pneumonia, one with no complications, no comorbidities, will have the support value of around 56%. But another patient with pneumonia who maybe is older, has comorbidities, has a more severe presentation of pneumonia, will have a lower support value, 30-something%. So even this is currently understated since the current coding practices don't really prioritize encoding all of the secondary diagnoses, all of the procedures, etc. So we're kind of missing out on complexity that's not currently being reported. The third thing is that ACR payments emphasize the single claim with no overall picture of service utilization or hospital performance, such that at present, quality of care, as Val said, does not directly impact how providers are paid. As such, the ACR doesn't really incentivize providers to monitor their own quality of service delivery. So ACR, the system, doesn't really routinely collect data that can promptly identify systemic trends in things like upcoding or overpayment. And in a previous study by Val, an assessment of non-representative hospitals found that 78 to 85% do track complications and inpatient deaths. However, only 22% track post-discharge deaths, only 31% track readmissions within 30 days, and only 34% track avoidable readmissions. So that study was a non-representative study. What we did this year was do an analysis of patient readmissions using all of PhilHealth inpatient e-claims data from 2018 to 2023. And during this time, 2023, there was still a rule called the single period of confinement. It meant that patients were paying for readmissions within 30 days out of pocket on their own. And we can see that the most exposed to risk were the most vulnerable groups. I mean, this analysis was possible using ACR data, yes, but there were definitely limitations to that data. Chief among them is that these metrics are, as Val also said, not really being measured right now. So for example, through this analysis, we were able to show the need for a readmission monitoring framework that distinguishes between all readmissions and different types of readmissions. But who exactly are the patients being put at the greatest disadvantage? Well, there's the elderly. So in our analysis, we found that patients over 60 years old made up the greatest share of avoidable readmissions and hospital-acquired complication-related readmissions from 2018 to 2023. Also, the poorest Filipinos. So indigent members, sponsored members, and senior citizens without income represented the majority of avoidable and HAC-related readmissions. And also patients with pre-existing comorbidities. So patients with moderate to catastrophic comorbidities and complications received 11% to 23% less financial support than patients without any comorbidities or complications. And so policy updates are needed. But even with these updates, standards should be clearly communicated and transparent. But what we found was in previous years, when updates and additions were made to the ACR, these were often done ad hoc and the processes were kind of opaque to the public. So the original implementation guidelines for ACR, for example, did not report how case rates were costed or what subset of claims data were used for this costing process. And a system wasn't really provided for updating the case rates in light of new technology, standards of care, or even inflation. So it could not really be determined how much the cost of service delivery ACR was intended to cover. When new benefit packages or updates to old case rates were done, these were done slowly and selectively, often on a case-per-case basis. We reviewed the 24 PhilHealth policies released from 2013 to 2024 relating to additions and payments to the ACR payment rates. Because policy processes and even the policies being outputted should be evaluated. We found that new benefit packages or updates were shifting in priority over the decade. So at first, 2013, 2014, it really focused on establishing the ACR. And then later on, we see more reactive policies and updating selective benefits between the next succeeding years, or both, which happened in 2016, to the release of the guiding principles for the rationalized inpatient case rate, which committed to across-the-board increases to ACR payment rates, as well as the selective update of 2 benefits, high-risk pneumonia and acute stroke, in 2023, and then 4 benefits, breast cancer, neonatal sepsis, bronchial asthma, and hemodialysis in 2024. So what do we see? In previous years, the updates were very active and they didn't really provide a basis for prioritization of the selective update basis or why the increase at the time was the same across nearly all benefit packages when not all benefits are affected by medical inflation in the same way. But it just shows that when the PPM is this way, there are still gaps in transparency and communication in the policy updates. So this is data until early 2024 and ongoing reforms since then have change the way that things operate. So what do we mean by this PPM reform? This was a retrospective analysis, right? But at the same time, it's forward-looking as well. So prospective research for the ongoing PPM reforms, namely DRGs for hospital inpatient services, found that this reform is meant to deliver on the promises made in the UHC law. And what exactly does the UHC mandate? Section 18B mandates the shift to performance-driven, close-end prospective payments based on disease or diagnosis-related groupings. If you're not super familiar with DRGs, that's fine. We're going to go through that process as well. But the point is that these DRG payments should be performance-driven and based on accurate picture of services provided during the episode of care. So what exactly is the DRG? It starts with data. It starts with comprehensive data on the inpatient case to give a more complete picture of the patient admission. And that in turn will inform more realistic payment rates that reflect the actual resources that have been used. From the patient data, we take that data and put it through the DRG grouper. And the key feature of this is that you're able to classify patients into a group based on their clinical presentations and intensity of resources used to treat that patient case. And it accounts for the complexity of the case management based on things like disease severity, on comorbidities, and on complications. The routine collection of all of this information will allow for performance monitoring. With this data, both PhilHealth and providers can track hospital outputs, efficiency, service quality from this routinely collected data. And at each step of this process, you need regular review and adjustments. So in that way, you need good quality data, you need rigorous analysis, and you need to share this information and engage with relevant actors working on these or involved in these different activities. So where are we now? PhilHealth has committed to transitioning to the DRGs, to good data, to rigorous analysis, to engaging with providers. And we're very grateful for that work that they've been doing. So currently, we have adopted the Thai DRG version 5 grouping algorithm and are undergoing clinical expert consultations. PhilHealth has already developed the Philippine DRG grouper software and has launched shadow billing, which is the use of this interim claim form called the CF5 to collect all of this patient data, and also the ESOA to collect the financial data or the resources associated with treating the patients. And we have explored different supplemental policies that are also needed for DRG implementation, like readmission monitoring, fraud control, and health information system improvement. But of course, there are still a ways to go. So some of these next steps include calculating the relative weights for the DRG, which is how much are we weighing these different groups so that we can pay providers accordingly. And for that, we need data. We need a lot of data. And the historical e-claims data is limited because, as we have seen, the typical is only to write down for the 2 case rates. So in that way, it needs a lot of participation and active engagement of providers to participate in shadow billing, and the submission of quality CF5 and ESOA to have an accurate picture of the resources needed in patient treatment. At the same time, we are refining the Philippine DRG grouping logic based on local expert feedback to make it appropriate for the Philippine setting. And we are also working towards using all of that information to determine the inpatient global budget and DRG base rate. So that leads to our main conclusions. Conclusion 1. Forget everything I just showed you and just remember this, that systematic and empirical assessments of our health financing system are possible. And these analyses are the backbone of evidence-based and nationally appropriate PPM reforms. Second, that shifting to a DRG-based payment system is not a panacea for our payment challenges. We will need institutional changes in order to ensure that DRGs bring us closer to UHC. Because PPM does not operate in isolation. We need policies to facilitate implementation, sometimes ones that are less obvious, flashy, or popular. We need institutional reform to update the roles of our human resources and to use new technologies. We need changes in practices and norms, from basic building blocks like our clinical coding practices to our social imagination of what we can do with large data sets as a tool to monitor and benchmark efficient and quality services. And these are in turn made possible by collaboration and partnerships, by information sharing and stakeholder engagement, and the culture of accountability. And this includes the active roles of regulators like the DOH, the role of researchers and universities, of watchdog institutions and providers throughout the process. Because DRGs alone are just a concept, or they're just a theoretical payment system. To make it a reality, we need to have support and cooperation for DRGs through engagement with pros, with hospital administrators and providers, and to invest in strong data governance, to strengthen clinical coding capacity, to build a culture of data utilization and feedback, and to incorporate quality safeguards, as well as being able to implement periodic updates, like tying the regular grouper updates to relevant clinical developments and hospital charge data to keep rates responsive, and establish transparency mechanisms to publish updates and all of the basis for these updates. And finally, to be able to assess progress and impacts for reforms. By reviewing how PPM policies are contributing to the attainment of UHC, we should leverage data collected in routine or program operations to evaluate progress and identify areas for improvement and change. And the thing to note, and the thing I'd like to end with, is that it can be done. We really appreciate that during the term of the current PCEO, attention to monitoring and active utilization of data to assess efficiency has led to tangible and meaningful change in PhilHealth operations. See, we assessed the turnaround time for claims in 2023, and in the best case with no return to hospital, median TAT was 87 days. For claims with return to hospital, it was more than twice as long, 221 days. But understanding what drives inefficiency, leading to targeting concrete improvements this year, average TAT is 22 days. And it can be done. So PPM reform, together with improvements in institutional infrastructure, can improve the way policies interface with providers and in turn the lives of Filipinos. Thank you.
Thank you, Ms. Sivan, for your comprehensive analysis of the evolution and challenges of provider payment systems in the Philippines. Your work, along with the rest of the Health Economics and Finance programs, strengthens the evidence base needed to advance fair, responsive, and truly collaborative reforms. Now, our second presentation examines hospital performance using evidence from social health insurance claims. Our next speaker is a senior technical specialist at PIDS. She holds double degrees of Doctor of Medicine and MBA from the Ateneo School of Medicine and Public Health, and a Master of Public Management degree with a focus on health governance from the Ateneo School of Government. A former doctor to the barrio, she has experience in community public health and local health systems development. Please welcome Dr. Sarah Reem Hesham Mohamed Hagag.
Good morning, everyone. So in the last presentation, Vanessa talked about how data can be used to drive evidence-based policy. So this is exactly what we tried to do with the existing claims data that we had in previous years. So we tried to measure hospital performance in the Philippines using quality, efficiency, and equity indicators from the social health insurance claims in the past. So let's begin. Let's start with, sorry. Okay. Next slide. Okay, let's start with what we already know about the hospital sector. So firstly, in terms of supply, we know that most of the high capacity beds are DOH hospitals, while many LGU hospitals are level 1 and infirmary. Second, private hospitals hold a big share of level 1 and 2 beds, but their presence varies widely across provinces, and they tend to be stronger in wealthier areas. And more importantly, we really still see gaps in the overall supply of hospital services. While it is good that the number of hospital beds have increased in recent years, population growth has outpaced this growth in hospital beds. So as a result, the bed to population ratio has actually declined from 1990 to 2024. Now it's only 0.93. And finally, these gaps are not evenly distributed. Many provinces continue to face limited access to hospital care, showing that disparities are concentrated in specific geographic areas. Next slide. Health spending has also grown at fast rates in recent years, and Doc Val showed it in the presentation earlier. And out of this growth in health spending, a large chunk of this is hospital spending. So around 39% in 2024 of current health expenditures was spent on hospitals. And hospital spending has been growing about 12% every year from 2019 to 2024. Next slide, please. So we talked about the supply side. Now we will talk about the demand. Public hospitals still carry most of the inpatient admissions, and around 60% of all admissions are in public hospitals. And where patients go depend a lot on income. We know that higher income groups would prefer to go to private hospitals, while lower income groups rely on public facilities. And this shows a clear market segmentation by socioeconomic status. Also, public hospitals serve more people at a lower cost per patient. Next slide, please. So zooming out, now we have to ask, since we're spending so much on hospitals and we're increasing health spending, are we really achieving our financing objectives? So we have financial risk protection or increase in health gain, but there are also intermediate objectives that we have to measure, such as, are we reaching efficiency goals, quality goals, and equity goals in our health system? Next slide, please. And PhilHealth plays a crucial role as a purchaser of hospital services, as a strategic purchaser. And part of this role is to monitor provider performance and the quality of care, so we can assess how well the health system is working and whether we are meeting our financing goals. And as we move into provider payment reforms, such as the DRG-GB era, it becomes more important for PhilHealth to track how hospitals perform and the level of quality they deliver, so payments can support the outcomes we want to achieve. Next slide. So our objective in the study is to measure hospital performance using different efficiency, quality, and equity measures. And this is not a comprehensive list, but this is what was possible with the claims data. So we'll go. Next slide. PhilHealth data is an important source of information for assessing facility performance on equity, efficiency, and costs. For example, in 2023, over 70% of patients used PhilHealth benefits during their hospital admissions. This means that PhilHealth data is such an important resource because it provides representative and reliable data for assessing facility performance, particularly in terms of equity, efficiency, and costs. Next slide. So why do we need to measure these indicators? Under the old system, hospitals are paid based on volume, regardless of efficiency, quality, or patient outcomes. So this kind of creates incentives for hospitals to overprovide or to not prioritize quality of care. So performance-based purchasing and the DRG-GB system tries to flip this. It tries to reward hospitals for delivering better outcomes, safer care, and more efficient use of resources. And it also allows predictable financing while pushing them to manage costs, reduce unnecessary admissions, and this improves the coordination of care. Next slide. So in HEFP, we have cleaned and processed large-scale claims data with 75 million data points. And we have also set up a data pipeline where we can extract data from multiple sources. We are able to store clean, large-scale data with millions of data points. We can connect multiple data sets together, and we can create nuanced analyses to derive insights that are useful for policy. And that is exactly what we did with this analysis. And we used the e-claims data from 2018 to 2023, and we used the PhilHealth list of accredited healthcare institutions, and we did additional processing. For readmissions, we used criteria from multiple countries for how do we assess whether an admission is a readmission and whether it's avoidable or unavoidable. So we used criteria from different countries. We also mapped the diagnosis variables using the IHME-GBD cost list so that we know what diseases are high cost, or the high cost users, why are they being admitted? We also map diagnosis variables for ACSCs using the World Bank ACSC key. And finally, we derived relative weights from the Thai grouper for case mix adjustments. Next slide. So we're just showing the data exclusion. So from 75 million claims, for this specific analysis, we used 2023 data. So we used 5.8 million claims in this paper. So let's begin with the results. For efficiency, we analyzed efficiency indicators, next slide, such as total charge per admission, total charge per inpatient day, average length of stay, and case mix adjustment average length of stay. Next slide. And results showed that we found that private hospitals consistently had higher median charges per admission and average charge per inpatient day compared to their public counterparts. And this is sort of expected. The median charge per admission in private hospitals is 2 to 5 times higher than in public hospitals. However, the difference escalates by service capability. In public hospitals, the increase in charges across levels is relatively gradual, as you can see in the bar graph. But in private hospitals, the charges increase steeply as you go along the service capability of hospitals. And in level 3 facilities, the median charge per admission and charge per inpatient day is around 3 times higher than in public level 3 facilities. Next slide. So we might argue that perhaps private hospitals simply just have more complex cases. That's why they charge more for their admissions. But we also we accounted for this by adjusting for case mix. And the pattern still holds. This is the case mix adjusted charge per admission. And private facilities continue to have higher charges per admission than public hospitals, controlling for case complexity, although the gap becomes smaller after adjustment. Next slide, please. In contrast, patients on average are staying longer in public facilities than in private facilities. So the average length of stay in public facilities is longer than private facilities. And if you look at the bar graph on the left, average length of stay increases with increasing service capacity. And this is expected. Since level 3 facilities would have more complex cases, you would have longer hospitalizations, etc. So it would be difficult to benchmark level 3 facilities versus level 2 facilities with this measure alone. This is why on the bar graph on the right, we also case mix adjusted the average length of stay. And we see that the inverse is true now. In the figure on the right, we start to see that higher level facilities are actually more efficient in terms of length of stay compared to lower service counterparts, once case complexity is accounted for. Next slide. So now we go on to the stochastic frontier analysis. Another way to measure efficiency is to assess how far hospitals are from the production or cost frontier and to measure relative inefficiency. So we use the Cobb-Douglas equation to give efficiency scores to hospitals. Next slide. And results of the SFA show that public hospitals, which is the red line, are clustered at higher efficiency scores with a sharp peak around 0.9, suggesting that they generally operate more efficiently, meaning they can generate more admissions with less input. In contrast, private hospitals, or the blue line, have wider, more spread out distribution, with many hospitals operating at lower efficiency levels in generating PhilHealth covered admissions. Next slide. We also calculated the mean efficiency scores nationally and for each region for both public and private facilities. Nationally, public hospitals operated at 82.4% efficiency, suggesting relatively strong performance in converting resources into PhilHealth covered admissions compared to private facilities. And private hospitals were relatively less efficient, operating at 49.2% efficiency. And we can also see significant variation across regions, especially with the private facilities, the blue bars. So there's more variation across regions for private facilities, especially in NCR, where it's surprising that the efficiency score is lower for private facilities.
Dali natin sa TV.
So another way to analyze efficiency is through high-cost utilization and high-cost admissions. And these assess individuals or diseases that drive a disproportionate high share of spending or PhilHealth reimbursement. And we analyzed it in 2 ways. First, we characterized the number of claims that account for about 80% of hospital charges. And second, we characterized the top 5% of PhilHealth claimants with the highest reimbursements. And this is what we found. Our analysis showed that majority of the charges are concentrated only on 32.4% of the admissions. So 80% of hospital bills in the Philippines are only in 32.4% of admissions. And these admissions are concentrated, not surprisingly, in level 3 hospitals and private hospitals, which suggests higher case complexity and higher costs of care. Next slide. Also, we have found that PhilHealth has been spending 20% of its total reimbursements on the top 5% of claimants, 2023. And these claimants also accounted for 27% of total charges nationwide. So only the top 5% claimants in 2023, they already account for a fifth of the reimbursements for PhilHealth. And not driving most of these admissions. In fact, 66% of the high-cost users were admitted for NCDs, and neoplasms alone accounted for 10% of high-cost users. So now we would start to think, where can we prevent these high-cost hospitalizations? Should we invest more in screening, etc.? Especially since neoplasm alone is accounting for a lot of these. Next slide. So another way to measure efficiency is through ambulatory care sensitive conditions. These are potentially preventable admissions. And when these cases appear in hospitals, it means there might have been weaknesses in primary health care. So while they're not direct measures of hospital efficiency, they reflect broader health system inefficiencies because they shunt resources away towards preventable cases. So we are spending on them when they could have been preventable. So they are general health system inefficiencies. And we have found that in 2024, next slide, please. Around 33% in 2024 of 33% of admissions could have been avoided if patients had timely access to primary health care. And drivers of ACSEs are pneumonia, gastroenteritis, hypertension complications, admissions which are technically preventable if they were managed earlier at the primary care level. Next slide. We also found that the share of ACSEs was higher in private hospitals, and shares decreased with increasing service capability. So the burden of ACSEs is concentrated in private and lower level hospitals. Next slide, please. And this was an OLS regression just to identify factors linked to higher ACS admissions. And we found that private hospitals admit more ACSEs than public hospitals, around 0.45 standard deviations above the public hospital average. So it just confirms the findings earlier that it's private hospitals and lower level hospitals that admit more ACSs. Next slide. So now we go on to quality. For quality of care analysis, we focused on unplanned readmissions, which are often linked to poor quality of care, higher costs, and worse patient outcomes. And in the study, unplanned readmissions were defined as any unexpected readmission within 30 days of discharge. And these can be further categorized into 3 types, such as avoidable, due to complications, and unavoidable. Next slide, please. We found that private hospitals, especially higher level facilities, exhibit a clear gradient in unavoidable readmissions. Level 3 private hospitals exhibited the highest proportion of unavoidable readmissions, and the higher share in tertiary hospitals reflects their role in step-up care for complex and severe cases. However, in terms of avoidable complications, the shares are sort of almost the same, a little bit higher for private, but the differences are not that big. Nevertheless, in both sectors, we observe some similar increases in shares as service capability increases. Next slide. So, next slide, please. Yeah. So, on the other hand, patients in private hospitals were 12% less likely to have an avoidable readmission. Although the crude rates are higher in private hospitals, when service capability and location were controlled through a multinomial logic model, patients in private hospitals were actually 12% less likely to have an avoidable readmission relative to those in public hospitals. And level 3 hospitals were 49% less likely to have an avoidable readmission compared to infirmaries. Next slide. For readmissions, the slide before, yeah. For readmissions due to hospital-acquired complications, with public hospitals the reference, patients in private hospitals are 14% less likely to be readmitted due to complications compared to those in public hospitals. And patients in level 1 and level 2 hospitals are 1 and 22% more likely, respectively, to experience a readmission due to complications relative to infirmaries. While level 3 hospitals have a less chance, they're 34% less likely to be readmitted due to complications. So now we start to see variations based on ownership, service capability in terms of readmissions. So in summary, we have seen stark differences in technical efficiency and quality of care across hospital ownership and regions. So we compared private hospitals versus public hospitals, and this suggests that the private sector capacity can be maximized more. And 20% of PhilHealth spending is concentrated on the top 5% of highest cost claimants. ACSC rates remain high, especially in lower level and private hospitals, highlighting gaps in national primary healthcare and general health system inefficiencies. On the other hand, patients in private hospitals are less likely to experience avoidable and complications-related admissions. So what is this telling us? This suggests that efficiency must not be sought at the expense of quality. So while public hospitals might have higher volume with lesser inputs, we would find that they might have more readmissions, for example. So quality and efficiency must always go hand in hand. And while public hospitals cater to higher patient volumes, quality of care might be compromised. Next slide. So we would just try to demonstrate the feasibility of estimating provider efficiency and quality indicators to inform strategic purchasing. So this is arguably the first of its kind to use such large-scale claims data to analyze hospital efficiency, equity, quality. And this exercise may serve as a test case for PhilHealth. We should be able to routinely assess hospital performance, particularly in a regime shift towards performance-based and value-based payment systems. So that is the end of my presentation. Thank you very much.
Thank you very much, Dr. Hagag, for presenting these important findings on hospital performance. Your analysis highlights critical areas where reforms can support better outcomes for patients and facilities. Now to continue, our next presenter is a physician specializing in occupational health, a public health practitioner, and is a senior technical specialist at the Philippine Institute for Development Studies Health Economics and Finance program. Her research focuses on health systems and policy, particularly health financing reforms and their impact on achieving universal health care. She also works on issues in environmental health, including antimicrobial resistance, and continues to advocate for stronger occupational health systems in the Philippines. Currently, she leads the operations of the costing activities in partnership with the PhilHealth Benefits Development and Research Department. We now invite to the stage Dr. Leah Elora Conda.
Okay. Good morning, everyone. So we have listened in on the past two presentations by Van and Sarah, which highlighted analysis that can be done with existing data that we have. But aside from these, last year, we also endeavored into collecting data straight from stakeholders involved in these reforms. So the population, health facilities, and healthcare providers. So today, I'll share with you the baseline findings from our first comprehensive system-wide assessment supporting the rollout of the provider payment reforms done. Okay, so before we proceed with the study itself, just a bit of background. So with the enactment of the UHC Act of 2019, the Philippine healthcare landscape is evolving. So reforms are spread out in different key areas. First being governance through unified province-wide health systems. Second, through health financing, through expanded benefits and prospective payment reforms. Third, through service delivery, through stronger primary care and functional healthcare provider networks. And fourth, the health information systems through integrated EMRs and digitalization. So these reforms aim to move us toward a system that's more preventive, more integrated, and more financially protective. But reforms of this scale can have very different effects across areas. So we need baseline data, which will give us a fair, accurate starting point against which we will evaluate the reform's true impact. So under the 2023 GAA Specials provision, PIDS was tasked to provide analytical support for evaluating health benefit expansion and provider payment reforms, including the move towards the DRGs. And this baseline is the starting point for that work. So this figure summarizes our theory of change. UHC reforms influence the system from two sides. On the demand side, as prices fall through expanded benefits, we expect lower out-of-pocket spending, better protection from catastrophic costs, and ultimately higher use of preventive and primary care. But we can only track these shifts if we know the initial levels of awareness, utilization, and financial burden before the reforms. On the supply side, changes in provider payments and regulations shape how hospitals and primary healthcare providers deliver services. So these reforms can strengthen quality and rationalize services, but only if they are ready and incentives are aligned. So that's why the baseline is essential. So it gives us a clear before picture of our healthcare system. At the end line, this will allow DOH and PhilHealth to demonstrate which reforms truly improved access, quality, and financial protection. So for our general objective, we aim to conduct a baseline assessment of UHC reforms across 8 provinces, 4 intervention sites, and 4 comparators to enable a fair and evidence-based end-line evaluation. So we were guided by 3 specific objectives, the first one being able to develop a comprehensive framework as a lamppost for evaluating our province-wide health sector reform under the UHC Act. Second, to describe the characteristics of households, healthcare providers, and facilities in HCPN demonstration sites and control sites. And third, to identify major gaps in the current health system and potential opportunities for improvement. So in our study, we covered 8 provinces. Again, we have 4 intervention sites and 4 comparator sites selected through a structured process. So the intervention sites, namely Benguet, Laguna, Aklan, and Sarangani, were shortlisted by DOH and PhilHealth based on defined criteria. At the time of the study, these provinces were indicated as early implementers of these reforms. So the specific criteria are shown on the slide. Oops, okay. PIDS then identified 4 matched comparator provinces with similar population, health system features, and service delivery patterns. So by comparing both groups at the baseline and later on end line, we can see the true effects of the reforms. So to ensure that the baseline accurately reflects system conditions before UHC reforms roll out, our team designed and developed all the survey instruments and clinical vignettes used in this study. So we developed the first one, a population survey tool that captures household characteristics, healthcare access, utilization, health literacy, and patient attitude and behavior. The second one is a facility assessment tool that covers service availability, health workforce, governance and management, financial health, and quality of care. The third tool is a healthcare provider survey that captures knowledge and competency, compensation, coordination and referral, effort, motivation, continuity of care, and quality of care. And to support the provider survey, we also developed 2 clinical vignettes, each per discipline for general medicine, pediatrics, OBGYN, and surgery. So each of these vignettes actually replicate a full clinical encounter. So it allows us to evaluate history taking, diagnostics, treatment, and even identification of unnecessary tests. So together, these tools enabled us to collect data from 10,792 individuals across 2,617 households, 299 facilities with 65 hospitals and 234 rural health units, 1,134 providers with 441 physicians, 489 nurses, and 203 midwives, and we also administered 1,073 clinical vignettes. Developing these tools was crucial because existing data sets do not capture the combination of metrics from the patients, healthcare facilities, and providers that are needed to evaluate these reforms. So this baseline fills in that gap. So for our methodology, we use rigorous approaches across all stages. First one for facilities, which were selected through stratified random sampling, households through two-stage stratified cluster sampling, and providers through an adjusted sampling design with weights applied where appropriate. As for data collection, we use Survey CTO for households and providers and paper-based tools encoded into Kobo Toolbox for facilities. Clinical vignettes were open-ended, scored using standardized guidelines, and double-scored for reliability. And then we also pre-tested these tools and conducted a 5-day enumerator training and piloted it in a site selected by the study team. So data quality was ensured through field supervision, automated checks, and structured cleaning and analysis in data. So we now move into the baseline results. Given the vastness of the data, we'll only highlight selected key findings. Okay. For the population survey, we present a comprehensive profile of household and socio-demographic characteristics across the provinces. So households average 4 members and spend about 24,000 monthly, with most living in owned homes and having access to improved water and sanitation. Individuals, on average, are 33 years old, evenly split by sex, and largely educated to the secondary level, with many actively studying or employed. So this gives us a strong, grounded picture of the communities where UHC reforms will take root. So we now shift to these communities, to how these communities are actually faring in terms of health and well-being. Okay, so respondents generally report high health-related quality of life, with Aklan, Benguet, and Laguna showing the highest scores. In contrast, Mindanao provinces, especially Sarangani, show significantly lower and more variable results. So this points to clear geographic disparities in physical and mental well-being, likely linked to differences in access to care and underlying health condition. Now we look beyond well-being. We also assess health literacy using the Malaysian Health Literacy Survey questionnaire, covering healthcare, health promotion, disease prevention. So findings show that overall literacy was high, and among the domains, health promotion had the greatest weighted score. But this strong literacy doesn't always translate to better awareness or use of available health benefits, which leads us to the next finding. So despite strong health literacy, a significant share of the population remains practically uninsured, either not enrolled, inactive, or unsure of their PhilHealth status. Even among those who are covered, awareness of essential benefit packages, particularly outpatient services under consulta, remains low. So this disconnect between literacy and benefit awareness results in underutilization of services that should already be accessible. So from the results, we see that limited PhilHealth awareness and coverage translate into very low preventive care uptake. So only 7.4% of respondents access any preventive service in the past year, and essential screenings such as CBC, urinalysis, and X-ray are used by only a minority, with CBC being the most utilized. Use of cancer screenings are also almost non-existent. So these gaps show how being effectively uninsured or unaware of benefits suppresses early care seeking. And the same pattern continues in outpatient and inpatient care, pushing households to rely heavily on out-pocket payments. So across preventive, outpatient, and inpatient care, households remain financially vulnerable. So preventive services are still mostly paid out of pocket, and outpatient care is primarily funded from salaries and savings. And even during inpatient confinement, PhilHealth support is substantial, but families still shoulder much of the cost of medicines and supplies. So these patterns reveal persistent gaps in benefit awareness, coverage, and service availability. To understand this more clearly, we now look at actual inpatient costs and how much PhilHealth covers. So these figures underscore how costly inpatient care remains for many Filipino households. On average, a confinement results in around 82,000 pesos in total expenses, with medicines and laboratory tests adding to costs outside the facility. So while PhilHealth covers a portion of the bill, the average support value of 0.42 shows that families still shoulder more than half of their inpatient expenditures. This brings us to a broader issue on households' overall level of financial protection and the extent to which current health benefits cushion them from the economic burden of seeking care. So to understand these financial burdens from the system side, we also assess the readiness, capacity, and service availability of health facilities across the selected provinces. So the facility survey shows what the health system can actually deliver. So we start with the distribution of facilities. It is dominated by rural health units with very few higher level hospitals and a large share of facilities concentrated in Batangas, one of our study sites. So the financial picture across the health facilities shows persistent strain. So while a number of provinces report revenues higher than expenses, the overall pattern indicates fiscal pressure. So the median total expenses across hospitals reached 268 million pesos, exceeding the median total revenue of 245 million. So provinces such as Laguna, Iloilo, and Davao de Oro operate at a deficit. So a similar pattern is observed among rural health units, where the operating costs often surpass available budget from local government allocations and reimbursements. So these financial imbalances directly affect the resources available for service delivery, which sets the stage for capacity gaps and staffing shortages, which we will see in the next findings. So both hospitals and the RHUs attempt to deliver broad services despite limited resources. So across provinces, hospitals consistently deliver core diagnostic and emergency services with near universal availability of oxygen units, glucometers, and ECGs. However, gaps become evident in higher level services. So as you can see here, CT scan availability drops sharply in several provinces, with only about 25% in La Union and Batangas, 33.3% in Benguet and Iloilo, and none in Sarangani. Advanced imaging also, such as MRI, PET scan, is almost absent, with availability ranging from 0 to 6.7%. Mammography is also limited, with most provinces reporting none. And these gaps show that while basic diagnostics are in place, hospitals lack the advanced imaging and critical care capacity needed for more complex case management. So we now go into the rural health units. So the RHUs deliver essential primary care, but their equipment availability is uneven. So basic tools like thermometers, stethoscopes, and BP apparatuses are almost universally available, but emergency capability is limited, with resuscitators dropping to as low as 52% in some provinces, and the diagnostic capacity also varies. So while glucometers are common, EENT sets and fetal Dopplers are not. So these gaps weaken RHU's ability to manage emergencies and contribute to delays and avoidable referrals. So we now go into the staffing across these hospitals and RHUs, which, as you can see, is highly uneven. So some provinces like Aklan have hundreds of nurses, while others like Davao de Oro have fewer than 10. Many hospitals also operate with fewer than 4 general medicine physicians or even a single surgeon, and allied health staffing varies just as widely. So meanwhile, RHUs also rely heavily on midwives and barangay health workers, with primary care doctors often limited or absent. So these disparities highlight persistent staffing shortages that directly affect service delivery and set the context for provider performance seen in the next section. So just an overview of the providers involved in the study. Majority of them are female, so 76.7% are female, with nurses making up the largest share at 43%. So physician counts actually remain low, and Mindanao consistently has the fewest workers across all provider categories. So these patterns reinforce the staffing constraints observed in both hospitals and RHUs and highlight the uneven distribution of health workforce across the regions. So our analysis shows significant gaps in workforce development. So only 22% of the providers we interviewed and surveyed completed clinical training. Even fewer underwent refresher courses in the last 2 years. So these gaps in training translate into wide variability in clinical performance, which is evident in the clinical vignette results. So the clinical vignette results show substantial variability in provider performance. So as seen in this table of score results of doctors, history taking emerged as the strongest domain for physicians, but most providers still fall within average to below average range. So these patterns reflect the training deficits and staffing challenges shown earlier. And as well, these limitations are compounded by heavy workloads, especially in our primary care settings. So just to show you the other slides. So we also have the results for the, So these are the results for the nurses. And these are for the midwives. So aside from that, our results also showed that RHU providers handle high patient volumes despite staffing limitations, resulting in less time per patient for clinical care, in contrast to hospital providers who spend more time on clinical activities because they manage more complex cases. So these workload imbalances affect service quality and contribute to provider strain. These pressures are further intensified by fragmented referral systems that hinder continuity of care. So in our results, we also have findings that referral systems remain largely manual, relying on letters and phone calls. And only a third of the hospitals and even fewer RHUs use electronic records for referrals. So this fragmentation leads to delays, incomplete information transfer, and weak coordination across levels of care. So taken together with the earlier findings from the households and facilities, these results reinforce the need for stronger system readiness as UHC reforms continue to roll out. So as we close, it's important to note that this report does not yet offer policy recommendations. As a baseline, its role is to show where the system stands and provide a solid foundation for rigorous endline evaluation once the reforms roll out. So ahead of the endline, we see clear areas to strengthen. So the first one being to improve planning and project management. Second is for better communication and coordination. Third is to introduce additional data validation layers. Fourth is to consider reducing the variables collected for the endline survey. And lastly, conduct further analyses, especially across socioeconomic groups and geographic areas, which will help refine benefit design, target reforms more effectively, and strengthen implementation moving forward. So ultimately, this baseline provides the groundwork for understanding where the system stands today and where reforms must take hold, setting the stage for a more responsive, equitable, and financially protective health system for all Filipinos. So that ends my presentation. Thank you very much for your time and attention.
Thank you so much, Dr. Conda, for delivering such a detailed and insightful assessment of the sectoral performance of our systems. So it is the hope that this baseline assessment offered a holistic view of UHC implementation across multiple levels and stakeholders. Now, we will move on to the final section of our morning session, where the panel discussion, where our panelists will reflect and react on the previous presentations and share their insights according to their respective experiences and expertise. So may we, as we call your name, and I see that our seats of honor are ready, may we kindly request your presence on stage. So our first panelist has represented the country in international academic circles, being the first Filipino neurosurgeon invited as visiting professor at Harvard University's Brigham and Women's Hospital. In 2016, he was appointed as the director of the University of the Philippines, Philippine General Hospital, more commonly known as UPPGH, where he led initiatives to strengthen the hospital's service, training, and research programs anchored on health equity and access to quality care for all. Today, he continues to guide PGH toward global competitiveness, expanding its reach beyond Manila, and fostering collaborations. Let's give a warm welcome to Dr. Gerardo Gap-Legaspi. Our next panelist is a medical doctor and health systems consultant with more than a decade of involvement in supporting community health development in the Philippines. He currently sits as the founding board member and president of the Philippine Society of Public Health Physicians and the board president for the Public Health NGO Alliance for Improving Health Outcomes Incorporated. And he's also currently a health systems consultant for the Asian Development Bank. His past works include country-level, regional, and local involvements in setting up service delivery networks and guiding local UHC implementation, health financing, systems research, and community-level organization. May we call to the stage Dr. Michael Campued. Our third panelist is the director of the Asian Learning Institute, where he was its immediate past chief medical officer. And now he oversees its clinical research and medical training programs. As a hospital leader, he has helped develop centers of excellence, design value-based healthcare services, and expand access to high-quality and safe advanced medical care. He has also served as a DOH and PhilHealth consultant and developing the PhilHealth benchmark for accrediting hospitals and outpatient facilities, enhancing the Philippine National Formulary, and initiating the National Technology Assessment Program. Let's welcome to the stage Dr. Jose Acuin. And our last panelist is a fellow of the Philippine College of Chest Physicians and the Philippine College of Physicians, where she currently chairs the Universal Healthcare Committee. She received her Master in Advanced Studies in International Health from the University of Basel. And now she serves as the Medical Center Chief at Quirino Memorial Medical Center. May we give a warm welcome to Dr. Evelyn Victoria Reside. And to steer the wheel for this session, our moderator is both a lawyer and physician specializing in the field of public health, medical, and healthcare law. He is a senior lecturer and serves as supervised legal research advisor for the Juris Doctor degree program at the University of the Philippines College of Law. He also teaches medical jurisprudence and ethics, law and medicine at the UP College of Medicine. Currently, he serves as Senior Legal Associate at the UP Institute of Government and Law Reform. I now hand over the reins to Dr. Lee Edson Yarsi.
Thank you very much, Chanel. And I'd like to congratulate PIDS for a very comprehensive and impressive set of studies. I was listening to the presentation a while ago. I'm quite impressed with the level of detail and analysis of data that they have provided. So we have 30 minutes for this panel presentation, and I'd like to dive deep into the insights of our panelists. I'd like to start with Sir Gap. Sir Gap, I just want to ask for your general thoughts from the recommendations presented by PIDS, but I also want to specifically ask, as PGH Director, what are the challenges that you foresee in terms of transforming these recommendations from PIDS into actual concrete reforms? Go ahead, sir.
Thank you very much for giving me the first cut. Before I proceed, I'd like to thank, of course, PIDS and PhilHealth for doing all of this. It's a very refreshing activity and perspective that to receive such, to see such developments. I must be quite honest that I think all public hospital managers, especially the tertiary ones, that we have already mastered case rates in terms of being able to fully reimburse our cases almost as much as we can, if 100% possible. And this has led significantly to substantial savings and income for hospitals. So, in fact, when the DRG system was being proposed, of course, we all have to go think back on what we were doing and see how we will be able to adjust to that. But having heard all the presentation, and we were also part of the initial discussions when DRG was being studied. I think the potential is really great for improving not only how we do things, but why we do things. So my thoughts is that at first, of course, the most important part of going through this is the data that we'll use to propose the new system. I had my reservations in the when I was told that they were going to use the data of the last 3 years before 2024. And we all know that was post-COVID data, and we had our strong comment on that that might not be truly reflective. No? In fact, as an example, after COVID, because of the number of patients that have decreased, we had a yearly excess income or excess repeat budget of around 800 million until we finished it maybe a year ago. So just that maybe the data we had submitted for this is maybe not too accurate. But I see the very big potential for hospitals to be forced to be efficient. And because as we are given more liquidity with front loading, I think the administrators should probably have more control on the conduct of events in the hospital, most especially with the personnel. I see the DRG as a way for me to probably make one of our dreams in PGH a reality, which is faculty practice program. So because we might have enough money to actually pay the salary of faculty rather than just relying on the medical specialist or faculty salary. Having said that, I think the looking forward, the ways to probably improve what has already been started, and that I think we're really going on a very good footing here. One is, of course, going back to the costing system that we used to arrive at all the financial models that we have. Make sure that they are, of course, it's a general costing, but of course, each hospital especially those, I'm speaking as a teaching hospital, may have a different set of expenses not covered in the costing. And we all know that teaching hospitals will cost at least 10 to 20% more than most other service hospitals. So this is probably one area that we have to go to. And I'm just happy that our President CEO mentioned about the needs-based costing, wherein maybe we give more to those who do the jobs that other people don't want to do. I think that's really important, so that we encourage people. In fact, I told him that if you want more doctors in the primary care field, maybe you should pay them the same as surgeons, or maybe the same as neurosurgeons. So as far as costing, sir, I think we also need to consider the high complexity of maybe the big hospitals that they go to. The other one will be, of course, the need for a good IT system. I think that's basic, very basic now. We cannot escape from that reality. The things that used to work before have been superseded by the huge demand on data nowadays. Number three probably will be the adjustment for surges in the hospitals. Like, I'm again talking from the trenches of PGH, where we have this massive poisoning in Quezon that 1,000 patients start coming to us, or maybe a leptospirosis outbreak, or a severe case of infectious like the pandemic. COVID. So these are the adjustments that the risk adjusted payment also that we need to, maybe supplemental budgets for this particular case. And number four, I think one way to make this work also is that doctors have to start looking, or systems have to start looking to transforming their systems into a different culture. The clinical practice guidelines, or the less variations of how we do things.
Or standard of care.
It has to be, standard of care has to be. If you're going to measure anything, if you're going to measure across hospitals, across systems, it has to be standardized. No? I think among these are probably the four areas that I think we can improve on this.
Thank you very much, Sir Gap. And I want to jump in from that thought to Dr. Resida. There were a lot of recommendation, DRGs, there were case mix, global budgeting, a lot of these reforms. From your perspective, Dr. Resida, what do you think are the challenges that we should surmount or overcome so that we can transform these recommendations into something that our patients in public hospitals can really benefit from?
Well, thank you very much for starting the ball rolling, Dr. Gap. Just to give everyone an idea of our hospital, Quirino Memorial Medical Center is currently an evolving hospital, transforming from 500 to 1,000 beds. And we are a DOH hospital that is a national hospital. Therefore, we depend on the national budget. But because we can also retain our income, we can also augment our finances using this strategy of combining PhilHealth reimbursements and other sources of government funding, plus our own income, which we generate through other services as well. So currently, what we are seeing with all the information about DRGs, the global budget, it's actually something that we still have to get a good grasp about, because we know for a fact that because QMMC is one of those pilot hospitals also for PIDS and PhilHealth, and so we're looking forward to the more implementable aspects of the DRGs and the other financing and the financing scheme in general, especially since we're talking now about efficiency, about quality, when we all know that if DOH as a designates their government hospitals into specialty centers, and QMMC is a specialty center for an advanced specialty center for brain and spine. And we all know that stroke patients or patients with brain conditions, they take more than just the usual length of stay in the
Very
hospital. It's just like cancer cases and other chronic cases which come to us. The pressure to stay within a specific length of stay will be very difficult for us to deal with, especially if there are no local metrics for this. What are the acceptable length of stay for these chronic conditions? There are no metrics actually for this. And of course, regarding the push for primary care, even level 3 hospitals, and I know Dr. Gap also experiences this, the pressure on level 3 hospitals to also participate in uplifting primary care, is there. Apex hospitals, level 3 hospitals, we are still pushed to involve ourselves in the current programs of the Bukas Center, of the Purok Kalusugan, of Secretary Herbosa. No? So instead of our hospital-based approach to providing service, we have to deal with extending our services even beyond the hospital, especially since we are now talking about the quality of care, which includes decrease in rehospitalization or readmissions, which we feel can be a multi-sectoral project in itself and not necessarily something that hospitals should be measured against. So those are just some of my initial thoughts. There are more. These are some of my initial thoughts about this. And of course, as a hospital, we're trying our best also to reach out to our healthcare provider network of other health facilities. We're training them, we're approaching them for knowledge transfer as well. And these are efforts that are not reimbursable. We are also branching into traditional complementary integrative medicine, which PhilHealth has yet to recognize with reimbursements. We are also looking at, currently we already provide services, or we already have deep brain stimulation surgery, which PhilHealth does not cover. We have cochlear implants, which PhilHealth also does not cover. So there are so many.
The list goes on.
So there are so many things that that push us to always be better as hospitals, because the directive of the secretary is for DOH hospitals to be at par with private facilities. And so the investment is there. But the pressure to expand the service, not just within the hospital, is also part of our mandate. Thank you.
Thank you very much, Dr. Resida. And speaking of private hospitals, I want to first ask the thoughts of Dr. Aquin. Actually, sir, first you may give your insights on the presentation, but I also want to ask a bit more on the aspect of moving towards quality as indicator. And I've seen the presentation on efficiency being better in public hospitals as compared to private hospitals. So maybe some of your thoughts on those recommendations, sir.
Well, doon sa presentation, I really am amazed. Hindi ko masyadong maintindihan eh. Pero I think from what I can understand, from what our brilliant experts have told us, it's really that it's important that the health system itself irons out all of these inequities as a result of years and years of inappropriate payments, and but it's going to be a very difficult process. Although there are already lots of private hospitals being being built right now as I speak. Even sa Cavite, where I used to practice a lot. But they are small. So the challenge here really is although siyempre, most of the beds are in the public sector. Mahaba yung tail nung distribution, and that long tail of the distribution, which are made up of private hospitals, really, they're the ones that have lots of hugot sa PhilHealth. Ano si Edwin sila yung dapat na maging masaya about DRG and so on. But at this point, I would admit that kahit sa Asian hospital, we have very little understanding of how this is going to work. Okay, very aggressive yung PhilHealth regional office sa amin na mag-introduce ng yakap and gamot and OECB, yung emergency care benefit package. We have adopted that one. And we're already collecting, we're happy to say, from the outpatient emergency care benefit packages. But we still have to decide about the viability really of the yakap and gamot. And basically the main difficulty is for a private hospital that relies most of its revenues from inpatient care. It's a 60-40 split, or about 50-50 between inpatient and outpatient care, limiting inpatient admissions in favor of outpatient primary care services. Wala yun sa skill set ng private hospitals. So it's going to be a real shift. And even our patients themselves, magtataka yun. Why are you here in the communities now? Hindi ba Asian hospital kayo? So it's really not just about us being able to project ourselves as someone who's comfortable and who really wants to roll out preventive services. It's also about making sure that when they do get admitted, the care is going to be affordable. We're set to open a 30-bed, essentially no balance billing service ward in Asian Hospital. Incredible as it may seem, it's for the residents and the nurses and who are training and so on and so forth. And it's going to be a natural experiment because we'll then be able to compare the outcomes as well as the efficiencies of our private units there, as well as this unit, which I'm going to head anyway. But in terms of quality, kasi I was asking Edwin Mercado actually earlier. It's about more than 10 years ago, we actually developed the PhilHealth Bench Book, which people probably have already forgotten. And that one already spells out the quality indicators, and such as infection control and so on.
Not just on the output or input, really
not just
focus
output,
on the outcome.
but basically laying it down on the shoulders on the doorsteps of hospitals themselves to manage quality. Kasi right now, nangyayari, ang PhilHealth concludes about the quality of service from a distance. Meron silang medical evaluators who judge the quality of our services and our doctors' performance on the basis of guidelines from societies. The guidelines are not meant naman to rule. They're tools. They're meant to be bent and adopted to individual patient care and preferences and so on. But right now, we're having doctors being written by the legal team of PhilHealth about deviations from guidelines. And you know how devastating that can be to doctors when they get when lawyers from PhilHealth write to them. So I already told PhilHealth that's not the way to do it. We are able, at least you're talking about quality here, and you're talking about measurement of quality. In Asian Hospital kasi, we on an annual basis, we sort of summarize for every individual doctor their performance in terms of infection rates, adverse events, patient complaints, patient satisfaction, and so on. And it takes so much of effort talaga. May EMR na kami, pero mahirap pa rin i-churn out yung data. How much more? And we're one of 29 hospitals of Metro Pacific. Sabi nung group CMO namin, si Benchico, about 8 or 9 hospitals have EMRs. The rest do not. So paano ka mag-churn out ng infection rates pa lang ng ganon na on a per provider level, it's not even for the whole hospital level. If you're not able to have the resources to capture the data in an efficient way. Kasi hindi pwedeng paper. Magandang ginawa ng PhilHealth na electronic yung mga claims na ginamit. That should be that should really be the way of working already. Instead of going through paper charts. So unfortunately nga, hindi pa yon gano'n. There was a time na I was trying to get to review PhilHealth claims doon sa bodega nila. I stopped kasi I had allergy after that. So puro kahon-kahon.
And they studied millions
At
of
least yun,
they 90 million.
turned out our results. So that was
Very
fantastic.
impressive.
All I can see is that quality is expensive, especially if you don't have the information system to measure and to evaluate.
And eventually, I think the most important goal of the UHC is really creating better health outcomes from the public health perspective. And I want to ask Dr. Campued his insights from the different recommendations brought by PIDS. And what do you think it would take for us to create better health outcomes with all these reform recommendations?
Well, congratulations to PIDS. Parang confused yung feeling ko when I was seeing it because it was impressive, but it was depressing to see the baselines that we're working with. But yeah, yung intention of provider payment reforms na pinakita nila, no, we're shifting ACRs to DRG and the various types of payment. All these things were really structured specifically to try to drive better health outcomes. Pero there has to be parang an understanding, a common understanding of how these work, no? The various tools. Kasi for example, if we are going to look at the reform of bundling the payment, it was really meant to create coordination of care, no? Kasi you're not looking at it from discrete clinical state, but you're looking at it from throughout the care pathway. So reaction of the providers will have to be, they have to set up the system for coordinated care. And if that's the outcome that we're looking at, we have to look at continuity of care as an indicator. So ang gaganda ng mga pero remember, a lot of these indicators that we're gonna be looking at for better health outcomes has a black box of process indicators that we have to see. Timeliness, mga ganyan-ganyan. So for example, if you are going to move towards DRG and these things that will allow you now to cover for more than just the clinical costs, but also looking at social costs for the whole range of disease clusters. This will allow now to the providers to see patients on a more holistic way, diba? Kasi you're not anymore treating them based on procedure and volume. Kung gaano kadami. Right now, the system is rewarding volume. But if we are proceeding with the payment reforms that we are proposing, then these things will provide better health outcomes. Pero for example, it also has to set into the backdrop of the broader UHC reform. For example, yung healthcare provider networks. If PhilHealth will really get into the serious business of paying networks, that's when we can have a real shift, no? Kasi individual payment, patient to provider, the payment is stimulating the payment is stimulated by the service. Pero if you are looking at it from a network perspective, the payment can be stimulated by population outcomes. So for example, the payment for performance of reduced hospitalization will be provided to a network. Hindi mo naman pwede, yun nga yung sinasabi ko din in some of my talks, no? That's the weakness of individual payments. If patients don't experience quality care, they can't ask the doctor, can I refund my money? Kung hindi sila gumaling, hindi mo pwede. Pero if you are paying a network, you can have that demand. You can have that leverage as a purchaser. Tapos, you also have to have the host of payment designs, no? Capitation. Ang ganda nung sinabi din kanina, no? Dapat it's predetermined and front-loaded. Kasi this is, if that is the reform that we're taking, you're now allowing the providers to really look at the needs of the population and measure it more closely. Dahil that's what they're gonna demand as money payment, di ba? So, pagka ganun yun, it really changes the incentives for the providers and the system. Ang isang mahirap na dyan is achieving equity. No? Once you, kasi how do you now ensure that all these payments will get into will allow us to achieve equity in our services? Doon na papasok yung halimbawa, capitation, looking at the full population, ganyan-ganyan. So yeah, blended models of payment, all these reforms have to set within the backdrop of the UHC reform of creating networks of care will allow us to achieve better health outcomes. Pero ano yung hirap doon? Yung mga pinakita nila. Kulang tayo sa data, napakaraming pag-uusap and a lot of mental shifts that has to happen, and isa sa mga malaking trabaho ng DOH, how do you now regulate them? That's a very difficult task to do. You're gonna regulate a whole new design.
Right. It's a really complex and really broad conversation happening now in universal healthcare, and I really thank our panelists for sharing their thoughts. I'm looking at the audience, and we have a rich source of inputs as well. And we might have a time for one question. I see Dr. Benjo already raising his hand. So the floor is yours. And you can address the question to the previous presenters or to any of our panelists.
Good morning. So first of all, thank you to the presenters and the panelists. So I'm Benjo de la Armente, a physician and a health economist on faculty at the UP School of Economics and the UP College of Medicine. And it's also great to see colleagues from both the college and the school here today. So maybe just a comment and a question. So first comment on sort of the importance of the information management system. So my last job prior to coming home to join the faculty was at UCLA Health, the School of Medicine. And yung sinasabi ni Dr. Akuin na you could get it electronically and review what happened to the case. That we did that a lot. So we were reviewing, our group was the Healthcare Value Analytics group at the School of Medicine. And we were looking at the effects of a chronic kidney care program kasi they were also under a value-based program purchasing ng Medicare. And we were looking, okay, what are the reasons for readmission? It's volume related. So that's the goal. But yun talaga dapat, if we really want to look at quality, it's that level of information management. And connected to that, actually, I'm starting to work with a few firms, like a health analytics firm. We can actually start doing that, especially with AI and machine learning. So this group I'm working with, they're working with EMR data in a free form. It's not even ICD codes. And I just got disease groupers from the Agency for Healthcare Research and Quality, HRQ in the States. And then I just told them, okay, these are the 550 disease groupers. You have this open text na diagnosis firm. And within the week, they were able to return back to me, the grouper. So we already have these tools and we have the know-how. And if you're interested, we can talk.
Yes,
But
that's an offer.
Yeah. No. But so yun lang. I think it's really important that we have to strengthen this. Especially, I was also at the section of adult medicine sa PGH with Diana last week. We were trying to I was trying to get a lay of the land with PGH, and we already have these tools, especially with AI, that we can, once we sit down and really invest in these resources, we can actually make it happen now faster than we've ever been before. So that's my first comment. My second comment and question, I guess, would be, so I think with all the discussion, and I've some of you in the audience might have already heard me say this, but we've always been talking about the benefits, provider payment mechanism changes, but I still find the discussion regarding pricing very lacking and very deficient. We talk about costing, but the costing is a bit different from pricing behavior. And tulad nga sabi ni Sir Gap, public hospital managers have already managed, or already have a solution to all case rates. But again, kasi the incentives for public and private hospitals are a bit different. And I think, one thing that's very taboo among clinicians, even up to now, is talking about professional fees, pricing. And I think there really needs to be a lot more of discussion around that. Things like price discrimination. Among clinicians, parang it's very acceptable na, okay, for internists, for example, or the medical specialties, that they charge based on the room rate. But you're charging for the same service, you're the same person, so it's the same quality, but you're charging, based on the room rate. So parang in terms of its contribution to inflation, I think we need a better understanding of what are the drivers of inflation. So I think that's where we are severely lacking right now. Parang an understanding, and even among clinicians, an acceptance of, na we need to talk about prices.
And even under the Universal Healthcare Act, that's a specific area for regulation, pricing. Maybe just a response. Can I ask Dr. Edwin and maybe Dr. Gab to give their thoughts on this issue of pricing, costing, and what we can do using the Universal Healthcare Framework? Dr.
Napaka-sensitive na issue yan. And thank you for being the elephant in the room. Sabi kasi ni Edwin, I was asking him, pag binigyan mo kami ng global budget sa Asian or even the whole of Metro Pacific, kami na raw yung magde-determine ng PF ng mga doktor namin. Yung ayaw namin o yung hindi sumusunod, pwede mo o yung mga pasaway, pwede yung hindi mo bayaran. Or iba yung bayad sa kanila versus yung talagang sumusunod. And so I don't know if that's going to happen. But it's really politically charged. We approach it on the basis of bundled care. When we bundle or our package our services, we tend to make it closed by negotiating with the orthopods, kunyari, magkano ni replacement. Kasama na yung yung PF doon. Yes. We'll promote it as long as kasama yung inyong PF. But I agree with you, hindi pwedeng sweeping reform for that. Kailangan, every specialty has a sensitivity when it comes to pricing. And we can continue the discussion later if you want.
What do you think, Sir Gab?
Yeah, I think as a teaching hospital, we encounter that a lot. First, our if you compare the urinalysis in PGH, it's 120 pesos. If you go across the street to the labs there, it's 60 pesos, 80 pesos. And I asked our lab, why is the big difference? First, because the standard of our urinalysis has to be research standard. So your machine has to be validated as such as will be approved by clinical trial groups. Our medicines tend to be more expensive also, well, because of the inherent cost of money when companies deal with government agencies. And the other one is, of course, we tend to choose the innovator drugs. Another example is trastuzumab. We buy the sub-Q, which is 26,000, versus the IV, which is 9,000. Because it's more convenient for the doctors and for the patients. So there's a lot of variables also in terms of price. And you're not even talking about pricing of doctors' fees. I think that's one aspect that's going to be very challenging. If clinical practice guidelines and pathways is going to be challenging because of the stylized way of, that we were very used to doing, I think standardizing professional fees will also be challenging, as mentioned by Dr. Edwin, because we've been so used to the fee-for-service. I think the first thing that we need to get over, really, if you want to go to a DRG, is the fee-for-service culture. That is a free-for-all, especially in private practice, free-for-all system. So, but I agree, the only way to make this work is if everyone agrees on how to do it.
Thank you very much, Sir Gab. I was asked to wrap up, but of course, since we have important panelists, I just want to hear some final words from Mike's and Dr. Reside as well. Mike's?
So siguro I'll just react to the question of Benjo. A lot of work has to go to paradigm shifting discussions. So it's really convincing everyone that the goal of the care organizations we're setting up is to cap the cost. So acceptably, there will have to be unilateral fee schedules that have to be agreed upon. And this has to be discussed more in an evangelical way na this is meant to make our system more efficient and achieve our desired health outcomes. Pero yun yung kailangan gawin. Yeah.
Thank you, Mike. And finally, Dr. Reside, here.
Some ray of hope for UHC as the recently appointed, and the president is here, the recently appointed chair of the Philippine College of Physicians Committee on UHC. One of my first projects was to come up or organize a UHC summit for all PCP component societies such as PCCP, PHA, PCC, to come together, understand what UHC is about, because understandably not all practitioners will understand UHC at the level we want them to understand. And in that sense, the discussion on professional fees and service fees will become clearer and more robust. And that is something that will happen on December 6th. There are some people here who we have already invited to the summit. Thank you very much for saying yes to being our resource persons for the summit. We're looking forward to a very healthy discussion on professional fees after this. So we're starting the discussion, we're opening it up, and so hopefully this is also our way of helping PIDS and PhilHealth to come up with a more appropriate costing of services.
Thank you very much, Dr. Reside. The conversation on UHC would really require professional organizations, but I think even the academia, different members of the government, private sector, it's an ongoing conversation. And I hope we continue that conversation also in the afternoon where we can dive deeper on other concepts.
Welcome back, everyone. So I hope you've all satisfied your literal hunger with our scrumptious lunch graciously prepared by our venue, the Marco Polo Ortigas, Manila. And we'd like to welcome back as well our live stream audience. So for this afternoon session, we will now head into our second session entitled A Deep Dive into the UHC Building Blocks. To begin, we now call once again Dr. Valerie Gilbert Ulep to provide us a session overview and his presentation on health financing. Let's give him a warm round of applause.
Thank you. So before I discuss our work on health financing, I would like to promote our new website. So can you... So this one, so you can download all the papers here and also in our PIDS website. And like if we will come up with a blog, etc., all those materials will be here. And aside from that, so yeah, this is the interface. And lastly, we are also developing a data explorer in which a data explorer. So there are there are 6 domains: health utilization, health outcomes, health financing, health human resources service delivery, and social determinants. So we try to estimate like all the critical indicators at the province level. The goal here is to really promote accountability and transparency. So we gathered different data sets from multiple government agencies, and the data team of PIDS tried to come up with and consolidate them and make it more public. So yeah, but it's not yet. No, it's not yet live, no? Okay, but yeah, like in the next few weeks and months, so you will be able to navigate all these indicators at the province level and further disaggregation by age, sex, etc. So okay, so that's it. Let's now move on to our first session on health financing. So again, So for this afternoon, we'll be talking about the building blocks. This morning, we presented some of the works on provider payment reforms and health outcomes or our performance when it comes to UHC, both in health outcomes and financial protection. But today we want to discuss or highlight some of the issues related to the inputs, meaning health financing, service delivery, capital investments, and IT. So I will be presenting for the health financing domain. I will be discussing our recent work entitled Piecing the Puzzle. So Piecing the Puzzle, addressing the multi-payer and fragmented health financing system in the Philippines, right? So I just want to mention that this is not actually a research paper, but it's a report that argues the need for us to consolidate our different sources of public financing, given the emerging multiple sources of public financing for health. So this one, it's just a report trying to argue the need to consolidate for us to achieve the goals of UHC. Okay. So this will be the objectives of my presentation. So discuss health spending in the Philippines and decompose the growth in government spending on health. San ba yung growth, right? Is it central, local, PhilHealth, etc.? Then we will try to do a little bit of the composition or decompose the growth of the government spending, right? 2 is describe the potential fragmentation in health financing in the Philippines. And lastly is to provide recommendation to address that problem, no, or challenge. And try to anchor the issue with our earlier discussion on provider payments and DRG. Okay. Next slide. So I'll start before I discuss the decomposition and the fragmentation in the health financing. I would like to start again the discussion of multi-payer system with understanding the growth of health spending in the Philippines. And I already presented this previous slide. Okay. So I already presented this morning. Next. So, okay. So over the years, health spending in the Philippines, both public and private, has more than doubled over the past decade, no? So even after we adjust for inflation and population growth. So in the left, you see the constant per capita spending rising steadily from mid-2000, but accelerating sharply after 2019. So I already discussed this issue this morning. So total health spending crossed the 1 trillion peso mark for the first time in 2021. And by 2024, the estimate is around 1.5 trillion. So as I've said, the economy is really growing, right? So it accounts for about 5% of, or 5.4% of the total economy. So in per capita terms or in per person terms, we've gone from roughly 3,000 pesos in 2000 to almost 12,000. That's around $200 today, no? So a 4-fold increase in real terms, meaning adjusted for inflation and population growth. So as I've said, this health spending already accounts for 5.4% of gross domestic product, which puts the Philippines in the same as many countries with similar income levels. Next slide. And yeah, I also discussed this morning. So what is the driver of this health growth in health spending? No? So when we look at what's driving the surge in health spending over the last decade, the story becomes very clear that the government spending is really the main driver. Obviously, household out-of-pocket is increasing, but the main engine really is the government. That is central, national, local government, and PhilHealth. So on the left, this is the decomposition of health spending in 2024. So government accounts for 44%, while out-of-pocket remains around 43%. So almost equal. So despite the growth, the system still, I would say, reliant on out-of-pocket. So on the right, so you want to see the growth index. The total value of government spending increased by almost 2.6 times. Again, even adjusting for population growth and inflation from 2014 to 2024. So in contrast, out-of-pocket only grew by about 1.6 times over the same period. So this means that the government has been the primary source of additional resources flowing into the system. I also presented this, next slide. So I also presented this slide this morning. So if we want to compare the government spending on health against our income level at the global level, the Philippines is actually right where we'd expect it to be. So it's very near the regression line or the average. So if you look at the line, countries with our income, same income level, typically spends around 3 to 4% of GDP on health through government, and that's exactly where the Philippines sits in 2015, 2019, and 2013. So the issue now is whether this underspending or this spending or spending pattern is related to or translate into better outcomes. Okay, so I also, next slide, I also want to kind of emphasize this again. So if we look at the past, so now let's analyze now the government health expenditure per capita or per person in the Philippines. So if you look at the past decade, government spending on health per capita has grown very rapidly. So and if you try to average the growth rate in the last 10 years, it's 9.3%. It's much higher than your GDP growth. So you can see the sharp rise started in 2020, 2021, when public spending crossed 1 trillion, right? And it's because of the COVID era or because of the COVID pandemic. Okay. So as I've said, this paper is really arguing the need for more consolidation. And in the paper, we attempted to understand the growth in government spending for health over the last decade. Sorry for the math, but this is how we tried to understand it. So mathematically and from a macro fiscal perspective, the growth in government spending on health can be broken down into 3 parts. Number one, and this process is called the decomposition, right? So this exercise answers a very simple but powerful question. Where exactly is the growth in health spending coming from? So this formula, sorry for the math again, this formula tells us that the change or the growth in government spending comes in 3 components. First is your income, right? Or the national income per capita. As the economy grows and people earn more, the government collects more taxes that expand the fiscal space and naturally raises public spending. 2 is increasing government expenditure in relation to its income. So this reflects how big the government is relative to the whole economy. So as you may know, GDP includes government, private, right? But as government increases, right, its expenditure, not only for health, that will also have an impact on government spending for health. And lastly is prioritization. If the government is deliberately giving more money to the sector, like from military to health, from education to health, so there is deliberate shift. And that's what we've seen during the syntaxes, that the main driver of growth really is prioritization because the government shifted its money from other sector to health. So So this one is just a multiplicative identity. So sorry for that. So it's income times the share of government to government expenditure to GDP, then the prioritization. So again, income, how big the public sector is, and how we prioritize. So why this decomposition matters, and I'll show you the numbers later, because it tells us whether the growth in health spending is intentional or accidental. So if spending is increasing only because of the economy, then it's not real prioritization. Then you can do more. If you want to mobilize more resources, then we need to prioritize. The growth that you see is just an artificial coming from the increasing national income or increasing government expenditure. So I think that's the point of this example. Next slide. So we tried to do the decomposition using government data, and this is what we see. So the main driver really is not prioritization. Our growth in government spending for health is driven mainly by the increasing income and increasing government expenditure. So there is a small contribution of prioritization, but the main driver really is that we just have our income is just increasing, right? And our general expenditure relation to GDP is also increasing. So that's the practical use of this exercise. So next slide. Now I want to, in the paper, we discuss a lot of the policy paradox that we observe. So now I would like to kind of delve into the policy paradox that we call it a policy paradox on the government spending on health that we have observed in the data, right? So let's break down the three sources of government spending. Central, that includes DOH, DSWD, etc., PhilHealth, and local government. And what the trends tells us of these three major sources of government spending. So first, look at PhilHealth. PhilHealth, its share to total government health spending has actually declined. And guess what? It's after the UHC law. It's 2019. There's a crisscross there. Over the past decade, this is surprising because the UHC Act envisions PhilHealth. The way I read it is that the PhilHealth was envisioned to be the main purchaser. So this trend shows the opposite, that PhilHealth's role in financing has weakened instead of expanding it or supporting it. And I want to highlight the crisscrossing just after the UHC Act. Second is the central government spending has grown very rapidly, especially after 2019. So again, despite the Mandanas Garcia ruling, which further decentralizes the government, you see that the central is rapidly increasing, right? And the last one is that LGU spending has remained flat and stagnant even after decentralization and further decentralization because of the Mandanas ruling. And we have another paper kasi it's not included here, but what we are seeing is that even if you increase the national transfer to local government, they won't spend on primary healthcare or government. So, but that's the point here. So despite the increase in NTA, we don't see a dramatic increase in LGU spending, right? So, okay. I also want to discuss a little bit on the concept of, or the health financing functions, or the concept of pooling. So I'm trying to break down different concepts as I go down to the main point. No? So in our report, we started discussing the critical role of health financing reforms in UHC. So as we may know this, we all know this, that the three functions of health financing are: number one, revenue collection. This is how we raise money, taxes, etc., or PhilHealth premiums. Second is purchasing. This is how we pool money, right? This is how we buy services from providers, right? Through DRG or capitation. And the last important piece is pooling. This means that combining all those funds so risks are shared across population, right? So I hope we have an understanding of the three main functions of health financing. So next slide. So okay, so next slide. So if we look at the literature, next slide. if you look at the literature, why do health systems pool their government resources for health? So what if they do not pool it? So number one, governments pool their resources because they want to, it shares the financial risk across individuals by consolidating health funds into larger unified pools. Number two is promotes cross-subsidization, the main point of PhilHealth, from healthy to sick, to rich to poor, to advance equity and efficiency. Third is to strengthen strategic purchasing and bargaining power of the health system. We have a lot of studies on this, on the decreasing leverage, financial leverage of PhilHealth, but that's part of the idea for us to pool the resources. And why? What if we do not? So number one, multiple uncoordinated scheme within the public sector. Weakens pooling and reduce equity, and explain why. Two is small fragmented pools within the government sector, especially within the government sector, means higher administration costs and weak bargaining power. Third is it leads to disparities in services and financial protection, undermining UHC goals. Next slide. So, in that report, we also tried to understand what do we mean by fragmentation. So fragmentation happens when different groups of the population are covered by separate, uncoordinated financing with varying revenue source. It could be PhilHealth, discretionary funds, etc., and payment arrangement. So an example to this is multiple schemes covering different population groups only. I'm going to cover only indigents, I'm going to cover only employed, etc. So that's a very clear example of a fragmentation with multiple schemes. Two is local government. So they call it the territorial pool. Local government manages health budgets independently. And third is central government funds only certain segments of the population. So in the report, there are two cases of fragmentation that we've discussed. Number one is the fragmentation in the Philippine health financing at the primary healthcare level. Next slide. So as we all know, we have 1,600 municipalities, and therefore we have 1,600 pools, each with its own health budget, priorities, and decision-making. In theory, every local government becomes its own financial pool. So if you look at studies, having multiple pools can actually work. So if each pool has a large enough population and strong financial capacity, but in the case of the Philippines, and many local governments are too small and their resources vary widely. So we argue that this system creates uneven capacity to deliver primary healthcare or basic services. So, and because each local government units operates independently, we also see major inefficiencies for more than 1,600 separate procurement processes, each buying small volumes, and that raises prices, weakens bargaining power, and leads to higher cost and wastage. At PIDS, we have a study on this on drugs. So, wide variation of prices across local governments. And with this potentially overlapping streams of public financing, LGU budget, PhilHealth reimbursement, national government grants, discretionary funds, this exacerbates the inequity. So richer local governments, and this is what you've seen in the study for HFEP, that richer local governments can leverage other funds because, number one, they are more politically and they have higher political and economic leverage, hence access to more national grants, especially when it's discretionary, and mobilize their own revenues. So while poorer local governments fall behind. And we've already presented this, that if you look at the spending of local government, may it be HR, operating expenses, you will see large variation. So, and this is what you see in the upper figure, in the upper section of this slide. So from a pooling perspective, from a territorial pooling perspective, this fragmentation weakens risk sharing because funds are spread across many uncoordinated pools rather than combined to protect the whole population. Next, so in that report, we also discuss the second case, which is multiple and overlapping sources of hospital revenues or for inpatient services, right? So I want to illustrate, next slide. I want to illustrate the a stylized interaction or illustration of hospital revenues and hospital expenditure. So in general, in our public hospital system, financing is deeply fragmented. Hospitals must balance their expenditure, that is capital expenditure, salaries, and operating costs, using multiple uncoordinated revenue streams from DOH, LGU, PhilHealth, and other national programs, and even out of pocket. So in that report, we argue that this setup is not optimal because it creates unequal fiscal capacity across hospital, wealthier local governments. DH hospitals receive more subsidies than the others, can hire more staff, etc., and upgrade facilities, while poorer local governments struggle to keep hospital functioning. Second is that the hospitals have unequal access to national grants and PhilHealth reimbursement. So while resource hospital can meet the documentation and administrative requirements, while others cannot, right? So the third argument is that when subsidies are insufficient or delayed, hospitals shift cost to patients. This means that patients in poor areas end up paying more out of pocket. And that's what we see, the variation in support value over time. And finally, fragmentation of DOH local government, PhilHealth, MAIP, out-of-pocket flows lead to misalignment of incentives and duplication, etc., etc. So in the report, next slide, we try to analyze the revenue sources of hospitals, because we argue that when you have overlapping revenue sources, the power of PhilHealth to negotiate will be weakened, right? So in that report, we also highlighted the emerging sources of public financing for health, which could be another source of fragmentation. An example to this is over the years, we've seen like the increasing MAIFIP, for example, and other disease-specific funds or pools, like cancer funds, etc., which plays an important role in expanding financial protection. And we argue that they do protect the population, but especially for patients that may still face gaps in PhilHealth coverage, right? But because these programs operate separately with their own eligibility rules, benefits, or the level of the tariff rate, the approval process, etc. So you will see, the point is that they create an unintentional or parallel financing streams within the health sector. So each stream solves a specific problem, but together they potentially make it hard to coordinate benefits, align incentives, plan resources across hospital and regions. We also, and if you look at this, we discuss the relationship of MAIFIP and PhilHealth subsidy, that MAIFIP is increasing and the PhilHealth subsidy is declining in recent years. Right? Next slide. In the paper, we also discuss again the emerging sources of public financing for health from non-DOH offices like PCSO, DSWD. The main point here is that they have different tariff rates. They have different processes in terms of eligibility, etc., etc. So there's that fragmentation at the operational level. So next slide. So in the paper, we tried to kind of address how do we move forward with this fragmentation. And next slide. So the first thing that we've dissected here is there are already existing institutional systems. One of the biggest reforms, for example, is the UHC system. For example, the creation of the Special Health Fund, or SHF, because this must be pursued, because the very problem of fragmentation at the primary healthcare level will try to address or minimize that pool. So today we have more than 1,600 LGU level pools, each with its own budget priorities. This creates massive fragmentation, inefficiency, inequalities, or inequities. So the UHC Act aims to consolidate into fewer 150 pool entities at the province or HC level. So through the SHF, PhilHealth payments, LGU budget, and national government subsidies are integrated into a unified provincial pool. So there's nothing fancy here. It's just we just want to reinforce that there is an existing legislative mechanism to address that very problem of fragmentation at the local level. And lastly, this is my last slide. So we also try to dissect how do we fix the fragmentation at the hospital level, especially in the private sector. So right now at the left, hospital must piece together revenues from multiple uncoordinated sources, DUH, LGU, etc., MAIFIP, PhilHealth. So in other countries, they try to address this, especially those with mature health financing systems. So the hospital revenues are simplified. So the idea there is that operating costs for routine, predictable services are financed by a single strategic purchaser like PhilHealth. So all the operating costs will be channeled by PhilHealth. For in this case, in the case of our system, this means that PhilHealth should finance the full operating costs through global budgets or DRG, while DOH and LGU fund capital and personnel, similar to Thailand, right? So there's a budget line item for PS and capital expenditure. But we also recognize that not all services fit inside the global budget. In many countries, they unbundle some of the services that are highly unpredictable. And in the paper, what we try to argue is that this might be the system or the services that might be funded through other sources other than PhilHealth. So the idea is for us to be very clear on what sources of financing should they cover. When it's salaries, it's capex, it's operating expenses that are highly predictable, could be under the global budget. And if politically not possible, then there are unbundled services that, like many other countries, try to remove from the global budget. And that could be reduced or that could be paid through other sources. So this is just, again, this is just a report trying to reinforce the need for us to, let's not, para eyes on the ball na we have already this institutional system and not to fragment further. So that's basically the idea of this report. So, but yeah, so thank you very much.
Thank you, Dr. Ulep, for another comprehensive and compelling discussion. Your work continues to shape our collective approach to navigating financing challenges under the UHC. Now, for our next topic, a study on capital investments will be discussed by a research specialist at the PIDS-HEFP. She graduated magna cum laude from the University of the Philippines, Diliman, with a bachelor's degree in political science. She is a policy research with published work focused on healthcare delivery, health financing, and health information systems. Let's all welcome Ms. Therese Jules Tomas.
Hello, good afternoon, everyone, and thank you for joining us in the Dissemination Forum. So, for today, I will briefly talk about the state of health capital investments in the Philippines and provide an assessment of the Department of Health's landmark program, the Health Facilities Enhancement Program, or HFEP. So, as we know, the enactment of the Universal Healthcare Law affirms the Philippines' commitment to ensuring equitable access to quality and affordable healthcare goods and services for all Filipinos. And aside from healthcare workers, a fundamental aspect of health service delivery includes capital investments or health capital outlay. These investments include construction projects, such as building new hospitals or renovating new health facilities, medical equipment, and even information and technology that support the provision of healthcare services. Therefore, how much a country invests in health capital outlay significantly impacts their capacity to meet the population's healthcare needs. Okay. So in the Philippines, the
health capital outlay are under the purview of local government units because of the country's high level of decentralization. So the local government code defines their responsibilities. So as we know, at the national level, the Department of Health sets policies and standards and provides technical assistance and sometimes even grants to help LGUs carry out their devolved functions. Provinces and HUCs, or highly urbanized cities, deliver primary care, but their main responsibility is hospital care. So they run infirmaries, level 1 district hospitals, and provincial hospitals that are usually level 2. And then we have municipalities and barangays that provide primary or basic health services through barangay health stations, health centers, rural health units, and other similar facilities. So decentralization enables more localized health solutions, but it can also create inequities. So this slide shows wide variations in health capital spending per capita across provinces and HUCs, pointing to unequal access to services and resources. So these gaps follow a clear socioeconomic gradient where spending ranges from about 485 pesos in the city of San Juan to almost zero in Camarines Sur. So these inequities, driven by differences in LGU's resources and capacity to invest in health infrastructure, led to the creation of HFEP. So the HFEP was launched by the DOH in 2008, and it aims to address the scarcity and uneven distribution of health facilities and equipment by providing capital investment grants to LGUs and public hospitals. Annually, it takes up a sizable share of DOH budget, about 11% in 2022 and 2023, and peaking at 29% in 2018. So the program originally used an equity approach, prioritizing remote and high poverty areas. But more recently, it follows the DOH's National Allocation Framework, which targets LGUs based on infrastructure gaps and capacities. So given the inequities in health infrastructure, this study examines whether HFEP has allocated grants equitably and efficiently based on LGU needs and identifies key challenges in the program's areas. In doing so, we also present the current state of health infrastructure in the Philippines. So to meet these objectives, we used a mixed methods convergent parallel design. On the quantitative side, we merged and analyzed secondary data from the DOH, the Philippine Statistics Authority, and the Bureau of Local Government and Finance. So data from DOH included HFEP administrative and financial data from 2008 to 2022, hospital statistical reports and financial statements from 2017 to 2020, and more. We also combined HFEP data with small area estimates of poverty incidence and LGU financial reports. And of course, to assess national and local spending on health infrastructure, we encoded financial data from multiple general appropriation acts and the national health accounts. As for the qualitative side, we conducted 28 semi-structured key informant interviews with HFEP implementers and recipients across all governance levels. We ensured that there is representation from all major island groups, and we continued interviews until data saturation was reached. And we analyzed the transcripts through content and thematic analysis, which were triangulated by the PIDS team. We also performed the policy scan and document review of HFEP-related guidelines and policies. And with these steps completed, what did we find? So first, bed capacity is not keeping up with population growth. So despite more beds, mostly from private sector investments that account for 51% of our total beds now, our bed-to-population ratio has actually fallen to 0.93 per 1,000, which is far below the 2.7 beds target in the Philippine Health Facility Development Plan. And the Philippines also remains below the ASEAN regional average, ranking second lowest in the region, just above Cambodia. At the provincial level, bed-to-population ratios highlight major inequities. So figure A shows that highly urbanized and wealthier areas have far more beds, while low-income provinces lag behind. So We have places like Batanes, Iloilo City, and Manila that exceed the 1 bed per 1,000 national standard, while provinces such as Sulu, Leyte, and Basilan fall as low as 0.03 to 0.33 beds per 1,000. And the figure on the right illustrates the relationship between bed to population ratio and poverty incidence. And what's important to look at here is the red dashed curve, which suggests an inverse relationship where areas with lower poverty incidence have more beds. So because of limited bed supply, many public hospitals have been operating beyond capacity. So from 2017 to 2019, bed occupancy rates exceeded 100%. Rates dipped in 2020 to 2021 as COVID wards filled and demand for non-COVID wards fell. But still, global evidence shows that occupancy above 85% compromises hospital outcomes. Many Filipinos depend on primary care at barangay health stations and rural health units. But out of the 44,000 barangays in the Philippines, there are only about 25,000 BHS or barangay health stations, despite the law requiring a 1-to-1 ratio. And likewise, only 17 provinces meet the target of 1 rural health unit per 20,000 population. So to address these gaps, the HFEP has funded 42,439 projects worth nearly 200 billion pesos from 2008 to 2022. Most focused on refurbishing and equipping facilities rather than expanding bed capacity. While 62% of projects target primary care, we still lack enough facilities for our growing population. So the focus on refurbishing and equipping, along with nominal increase in allocations, partly explains the decreasing average age of public fixed assets. Analysis of hospital financial statements from 2017 to 2020, which includes more than 1,000 hospitals nationwide, shows that the median age of public fixed assets steadily declined, except for a 1.9% rise in 2020. DOH hospitals show the greatest drop due to direct HFEP funding, and this indicates that public hospitals can replenish capital assets. Furthermore, in examining the financial health of Philippine hospitals, results show that the hospital's risk appetite for asset expansion through debt is higher in private than in public. And this also suggests that government hospitals are more reliant on subsidies for capital outlay. But despite this, significant gaps in health infrastructure remain. So what have been the challenges? First, LGUs are primarily responsible for health capital outlay, yet they only spend 4.41% of their capital budget on health infrastructure. Meanwhile, the national government covers 88% of total capital spending on health, even though HFEP was implemented only as an augmentation to LGU spending. So this indicates LGU's heavy reliance on HFEP for health capital outlay. Another challenge is planning. So in policy, LGUs and hospitals should propose HFEP-funded projects based on their local investment plans for health, the Philippine Health Facility Development Plan, and hospital development plans. In practice, local chief executives have discretion over these proposals and may prioritize or implement projects that may not necessarily be aligned with the locality's medium-term or long-term plans. And with these political interventions happening, delays and implementation challenges also arise, and the sustainability of the program is undermined. So in 2017, an audit finding by COA, there were actually several legislator-requested HFEP projects with the assurance of LGU counterparting through lot ownership, meaning the LGUs would provide lots for these HFEP projects. However, it was later discovered that the proposed sites were actually unsuitable. So they were too small, flood-prone, and they were affected by road widening projects. Additionally, per policy, HFEP project proposals are approved and granted following the National Allocation Framework, which the PIDS-HEFP team developed in 2021. So this allocation framework prioritizes LGUs based on public spending per capita, the presence of geographically isolated and disadvantaged areas, and poverty incidence per province. But in practice, HFEP budget allocations undergo legislative and political processes which may prioritize different value systems and that are neither explicit nor documented. So proposals from LGUs and hospitals should go through a screening process through the Centers for Health Development before they reach the HFEP Management Office and the Department of Budget Management. However, some LGUs deviate from this process, submitting through other DOH offices or maybe even through legislators, skipping the critical review and validation. Since 2010, DOH offices have received proposals that have not been vetted by the CHDs. As such, they mandated that unreviewed requests be returned to CHDs to ensure equity and fairness. So the flowchart on the left is a screenshot of the preferred route versus the non-preferred route for HFEP proposals and review process. So as we can see, as early as 2010, we have had problems in terms of the review and processing. So these deviations have led to inequitable HFEP funding. So using the HFEP data from 2008 to 2022, we found that there is little to no correlation between poverty incidence and HFEP appropriations per capita. We also measured LGU absorptive capacity using the overall absorptive capacity index, which shows an LGU's ability to spend their HFEP fundings. So on average, 42.2% of LGUs have an OACI below 1, meaning they cannot fully absorb their allocations, and this does not vary by socioeconomic status. So poor absorptive capacities among LGUs can be attributed to several things. One major reason is that LGUs have insufficient human resources. So LGUs often lack engineers and other technical personnel who can design, monitor, and assess the locality's infrastructure proposals. Meanwhile, HFEP projects are underutilized due to lack of human resources. So Section 6 of the 2019 GAA Special Provisions and other previous GAA Special Provisions authorizes the DOH to use no more than 1% of the HFEP project budget for administrative overhead expenses, such as hiring job order staff. While this helps address staffing challenges, the overall low budget for overhead expenses remains a major constraint. There is also an issue on reporting or monitoring and evaluation. So self-reporting by LGUs and DOH hospitals can improve data because they can be more accurate. But sometimes it also risks biased reporting. So in the recent years, there have been reports concerning unfinished and underutilized HFEP projects despite close monitoring of end users. A specific example is in 2022, we have an HFEP project for a regional hospital that is meant to raise bed capacity from 450 to 1,050 and was reported 53.91% complete and received payments equivalent to 338 million. But it was later confirmed by the Department of Health that the actual accomplishment was actually only at 14.68%. So after reviewing these challenges and the state of health infrastructure, these are some of the few steps that we can take to help improve the program. First is to stimulate LGU spending. DOH can implement fund matching or where high-capacity LGUs identified through the National Allocation Framework shall provide counterpart funding, while low-capacity LGUs shall receive comprehensive grants to ensure equitable development across all LGUs. Second, strengthen the program's monitoring and evaluation framework. So HFEP's success should be measured not just by disbursements or the number of completed projects, but also by indicators such as service utilization, bed-to-population ratios, and other health or service outcomes. Clear mechanisms should also exist to reject or return proposals submitted through the non-preferred routes, with additional deterrents to prevent funding misallocations. And finally, we have to align HFEP with province-wide health system needs. So provincial level planning ensures facilities and services that meet local needs. And along with this, DOH can also introduce service grants, or these are grants that are phased during a period, and they are a form of financial support covering not only the capital investments, but human resources, operational costs, and other technical assistance that are needed by the LGUs. In doing all these, we can implement and sustain capital investments and thus maximize their impact. So that is all for the state of health infrastructure investments in the Philippines and assessment of the HFEP. Thank you very much.
Thank you so much, Ms. Tomas, for your insightful and detailed presentation on capital investments in the health sector. Your work underscores the importance of strategic and sustained infrastructure development to support UHC. Our next presentation, which focuses on the health workforce, will be discussed by a technical specialist at the PIDS-HEFP. He holds a bachelor's degree in political science from the University of Santo Tomas. His work focuses on health systems and policy research, with published papers examining health financing and the governance of human resources for health remuneration in the Philippines. Let us call to the stage Mr. Louis E.R. Dagoy.
Hello, good afternoon, everyone. Today, I'll be discussing our discussion paper entitled Challenges and Policy Options in Health Human Resource Compensation, Magna Carta Compliance, and Salary Standardization. Next slide, please. So this is actually a compilation of 3 research studies that focuses on different aspects of HRH remuneration in the Philippines. So let's proceed. Next slide, please. For the presentation, flow of the presentation, I will do a brief overview on HRH supply in the country, tackle the study objectives, determine the key findings, and highlight the challenges and issues, and then we'll conclude with the policy recommendations. So to start off, here are some key facts about our HRH workforce. Using PSA and DOH data, we estimate that health workers make up 3% of the country's workforce. That's around 1.4 million workers out of a total of 4.45 million. The sector has grown by about 5% annually from 2010 to 2023, and the trend will likely continue to rise as healthcare demand rises. So over half of our HRH are actually employed in the private sector, around 53%, with areas such as NCR employing about 73% in the private health workforce. Now, in terms of HRH distribution by sex, women make up 68% of the total workforce, which underscores their central role in health service delivery. And by cadres, nurses constitute about the largest group, accounting for about 48% of all health workers. So these figures highlight the central role of health workforce in our society and our economy. So let's proceed. So now we'll focus on the supply and distribution and the labor market governance in the Philippines. So next slide, please. Hi. Okay. All right. So we use hospital HRH to provide information using the best available data to give an idea on how HRH workforce density is spread across provinces and HUCs. So first, we see a stark maldistribution of hospital health workers. This stacked bar shows physicians, nurses, midwives, and other cadres. And we can see that major cities have far more HRH per capita. HUCs in Metro Manila, for example, have 6 health workers per 1,000 population. Well, in contrast, some provinces have less than 1 per 1,000 actually. So this shows that access to healthcare is much better in urban areas, since it's more concentrated in those regions. Now, in terms of medical specialists, This is one of the earlier attempts to examine the distribution of medical specialists across the provinces and HUCs in the Philippines. So the maldistribution becomes even more striking when we look at specialists. The stacked bar includes physicians, surgeons, pediatricians, anesthesiologists, and OB/GYN specialists. So similarly, the trend follows the earlier graph. So cities like Quezon City, Manila, and Makati have higher densities, up to 3.34 specialists per thousand population, while some provinces even have as low as 0.5 per 1,000. So it really highlights the very limited access to specialized medical services in these areas. Now, we looked further at the relationship between health workforce density and poverty. So this graph shows an inverse pattern. Areas with higher poverty tend to have fewer health workers per 1,000 population. So this suggests that poorer areas struggle to attract and retain healthcare staff, which creates significant inequities in access to healthcare and quality of services provided. Now, after looking at the distribution, we examined how workloads are managed. So our analysis shows that public physicians face higher workloads than those in the private sector. The table shows median full-time equivalent, or FTE indicators, which standardize staff hours into a single measure of capacity. So this means that higher FTEs means that there are more available staff and a lower workload. And inversely, a lower FTE means lower staff and a higher workload for these facilities. So across all facility types, private facilities have higher FTEs, while public facilities manage larger patient volumes with fewer staff. So in this table, we can examine this in level 3 facilities. So if you can see that it really highlights the strain of the higher patient volumes for public facilities. Now, in terms of HRH governance, there are multiple approaches to compensate HRH across public and private sectors. So to capture this point, we created this matrix. Public physicians in government hospitals are salaried, but can earn extra through private ward fees and PhilHealth professional fees. In private hospitals, physicians mainly rely on user fees, private insurance, and PhilHealth reimbursements. Non-physicians in government facilities like nurses and midwives receive salaries and allowances, while community health workers in LGUs, barangay health workers in particular, only receive allowances. So public physicians in our HUs are also salaried under LGUs with limited PhilHealth capitation. And similarly, private clinic staff mostly earn from these direct fees. So these differences in compensation influence behavior, such as dual practice among public physicians, and these actually shape how services are delivered across the health system in the Philippines. Okay, so in terms of policies, a public HRH compensation is guided by the compensation and position classification system, with salaries updated through each evolution of the SSL. So Plantilla staff receive cash and non-cash benefits that's entitled to them by the Civil Service Commission, along with the hazard pay, subsistence, and laundry allowances that's entitled under the Magna Carta of Public Health Workers. Now, LGU spending, however, is limited by the personal services cap, while lastly, public HRH and PhilHealth accredited facilities may also receive a share of pooled PhilHealth funds. So compare this with private HRH salaries. It's largely market-driven, following only regional minimum wage rates, but benefits based on general labor standards, reflecting the sector's reliance on market forces rather than standardized policies. So let's take a look at further into the financing aspect. So based on the Philippine National Health Accounts, health workforce compensation makes up to 12 to 18% of the total health spending, as shown in this graph. This share has been increasing over the years, even after adjusting for inflation and population growth. Yet compared to other countries, the Philippines still spends relatively low on HRH. The WHO estimated in 2017, for example, that globally the health workforce accounts for 34% of the total health spending and 2.3% of GDP. So this gap highlights the need to examine HRH remuneration more closely in the Philippines actually. Now, looking at the figure on the left, national government spending on personal services per capita has risen sharply, reaching 660 pesos in 2023, about 30 times higher than 20 years ago, even when adjusting for population growth. But in contrast, LGU spending, shown on the right, is smaller and highly variable, averaging just 291 per capita and covering only 42% of the total public health personal services expenditure. So this scatter plot illustrates this variation. While some high-capacity LGUs with low poverty rates spend more, others do not. So this highlights significant disparities again in HRH financing across local governments. Now, using the LGU expenditure data from the Bureau of Local Government Finance, we found that on average, LGUs allocate 63% of their total health spending to personal services, similar to the national government. However, there is a wide variation. Some LGUs, for example, spend as much as 95% of their total health expenditure to salaries and benefits, while others only allocate 6%. Similarly, in the next graph, in terms of looking at PS expenditure within LGUs, we see a large difference in how they prioritize public health workers. In some highly urbanized cities like San Juan, Manila, and Mandaluyong, nearly 50% of the PS of their total locality goes to the health sector. In contrast, some LGUs allocate less than 5%. So, given the LGU's responsibility for other essential services, the lower allocations to health staff may reflect different priorities, but this can lead to understaffing and challenges in retaining health workers. So, proceeding in line with that, we come to highlight our studies objectives. So we've already provided a brief overview on governance and financing. So, as mentioned earlier, we have written 3 research papers on HRH compensation, each of which addresses one specific objective in this slide. So for this presentation, we will focus primarily on objective 1 by assessing the level and adequacy of HRH emolument spending in reference to global benchmarks. Now, to assess HRH remuneration in the Philippines, we use the framework by Yakowicz and colleagues in 2016, which looks at the health workers' utility, or how satisfied and likely they are to stay in their jobs. So the framework shows that compensation is a key factor, and it can be broken down into cash income, non-cash benefits, and unofficial payments. Each one of these components play a different role in overall job satisfaction and workforce retention. So for our analysis, we used mixed methods to provide a comprehensive view of HRH compensation. Qualitatively, we conducted a policy scan of government laws and policies. We've conducted 19 key informant interviews with national government agencies and LGU representatives, as well as conducted FGDs with medical societies and healthcare labor unions. And for our quantitative analysis, we analyzed numerous data sets. So these are, we sourced these from the Department of Health, the Philippine Statistics Authority, and the Bureau of Local Government Finance. So additionally, we also conducted a facility survey involving 1,000 public health workers across RHUs and level 3 up to level 3 hospitals in 8 study sites that captures a wide range of experience and perspectives on HRH, public HRH compensation. So, let's proceed to the key findings. So as mentioned earlier, we utilize Yakowicz framework on HRH utility. So we'll focus on the cash income and non-cash benefits to analyze HRH compensation in the Philippines. So for our key findings, in the private sector, the average base salary for health workers is below the national average. Our analysis with the occupational wage survey from the PSA shows that a private HRH worker earns almost 12,000 pesos less than a worker in the information and communication sector, with the highest average base salary in the Philippines. So when comparing these salaries between public and private HRH, we found that public health workers' pay has grown over the year through the inception of the SSL and targeted policy interventions. So the table on the left shows our analysis of PSA's occupational wage survey data and the rates prescribed in the SSL. So across most public sector cadres, the average monthly wage is 1.67 times higher than the national average. So nearly all public HRH earn more above this average, except for midwives, nursing aides, and radiologic technicians. And additionally, regarding the targeted policy interventions, one of the latest policies that enabled the increase in the monthly compensation of HRH was through the inception of a DBM budget circular in 2021, where it increased the salary pay grade of Nurse 1 from salary grade 11 into a salary grade 15. So now let's look at the policies. So in terms of what's written in the policies, the public sector has a more progressive history in HRH remuneration. In contrast, private health workers mainly follows the labor code, the OSH manual, the Department Order 182 in 2017, which stipulates general guidelines for private health facilities, and of course, the regional minimum wage rate in their respective areas. So this means their benefits are similar to those of other professions. It's important to note, however, that this checklist reflects what is written in policy. For instance, the 1999 implementing rules and regulations of the Magna Carta listed many entitled benefits, but over the years, the actual benefits provided to public health workers have been limited to the provision of the hazard pay, subsistence allowance, and the lodging allowance. So, to supplement our analysis, we actually reviewed remuneration policies for public health workers across ASEAN countries. So we utilized studies and available government documents. So most countries in ASEAN, most countries anchor their public HRH compensation in civil service structures, with standardized base salaries often supplemented by allowances and incentives. So one of the most common incentives are remote area assignment allowances or a service or function allowance. So these remote area allowances, in particular, address recruitment and retention challenges in underserved areas, sometimes adding up to 50% of the base pay of their public HRH, while service or function allowances are general incentives for civil servants or for critical professions. The full analysis is actually available in the paper. So another interesting part of HRH remuneration is in terms of PhilHealth professional fees or pooled funds. So it has just, since 2011, PhilHealth has used a case rate system for inpatient care. So around 30% goes to professional fees, while 40%, while for surgical procedures, around 40% are provided to the professional fees. Apologies. So with the professional fees, it actually allows physicians and non-physician staff to gather professional fees from the case rates, and in its implementation, there's actually no mandated policy, particularly for the private facilities, because the distribution is actually at the facility's discretion. So, and let's move on. So another interesting aspect of HRH remuneration is the pension. So retirement benefits also incentivize health workers to stay in the public sector. As corroborated as one of our KIIs, that's always been enticing for health workers why health workers practice in the public sector because of the pension plans available to them once they've rendered enough services and once they're eligible. So let's highlight key issues and challenges surrounding HRH compensation. So empirical evidence shows there's a clear wage gap between public and private health workers. So this pay difference can demoralize private sector workers and encourages health workers to move to the public sector or even seek other high-paying opportunities. Now, to support this, we've analyzed hospital financial statements from the Department of Health, health facility statistics reports, and across all facilities, public hospitals spend a higher share of total compensation on benefits and hazard pay, and while hospitals primarily attract staff through higher professional fees when compared to public health facilities. So although public health workers earn 17% more than their private counterparts, there still exists pay disparity within the public sector because of the SSL and the LGU code. So for instance, a public health worker in the first class city earns 100% of the SG15, while a public health worker in a sixth class municipality can only get 65% of what is entitled to them. So aside from that, because of the PS limitation, LGUs actually bypass it by hiring through contract of service or job orders. So since these funds are sourced from maintenance and other operating expenses, not from the and evades the PS cap, they actually resort to hiring a lot of staff here. And in some instances, the KIIs actually say that a lot of their staff, their entire staff are comprised more of COS or JO instead of the actual permanent employees. So another issue here is in terms of the Magna Carta compliance. So only about 70% LGUs comply with the Magna Carta benefits. So in order to be compliant with this, you have to provide 3 benefits: hazard pay, subsistence allowance, and the laundry allowance. So we can see that after 2019, there's been an increasing compliance rate over the years, and this suggests an improvement in terms of its provision to health workers. But it's also worth noting that these are only given to permanent employees, and these are not the COS or JO public health workers are not entitled to these benefits. So a quick figure, the illustration of the Magna Carta compliance over from 2014, 2018, and 2022, again, varies, and we can see that most of the non-compliant LGUs are actually in Luzon. So moving on, so we looked at actually the annual monetary supplements for doctors and allied health professionals, and across provinces, including per diems, PhilHealth sharing, allowances, cash gifts, and 13-month pay, PhilHealth sharing provides the largest benefit for these private public health workers. So actually, we can see the same trend here when we look at allied health professionals. And for non-cash benefits, actually, we can also see variation since time off or vacation and training opportunities and awards are mostly consistent, while subsidized housing and food rations remain limited and at times not even available to both medical doctors and physicians. So to wrap up, let's go to our key findings. So first, HRH wages and benefits in the Philippines are highly fragmented and unpredictable. Public health workers follow the SSL, LGU code, and Magna Carta, while private HRH rely on facility policies and market forces. So additionally, in the public sector, non-permanent staff face even greater stability, lacking benefits and job security, while policies such as the Magna Carta and PhilHealth professional fees are inconsistently applied due to fiscal limits and local practices, resulting in low transparency and unpredictability. Next, there are significant wage gaps between public and private health workers in the Philippines, as mentioned numerous times earlier. And although public HRH earn more, they actually have higher workloads. So And lastly, HRH compensation isn't just a workforce issue, it directly affects financial protection. So fragmented policies and incomplete payment systems push providers to rely on user fees and out-of-pocket payments. So our review shows that compensation policies are applied unevenly, and in terms of implementation, regarding the Magna Carta even, it's the local priorities even influence the provision of these benefits. So here are our policy recommendations. So the first policy recommendation is to create a national HRH support system for the public sector, a top-up kind of mechanism to help LGUs meet SSL designed salaries. And for the second recommendation is to fast-track a well-costed global budget system, which is already enabled through the UHC Act, to provide predictable upfront financing for health facilities. So together with these recommendations, these aim to create a more coherent, predictable, and equitable HRH compensation. And by strengthening the national support, standardizing pay across LGUs, and implementing a well-costed global budget, the government can reduce fragmentation, improve transparency, and boost workforce retention. So universal care cannot succeed without a well-compensated, well-supported, and well-motivated HRH workforce. And investing in HRH ensures that they are valued, fairly paid, and equipped, which lays the foundation for a health system that truly serves all Filipinos. Maraming salamat po.
Thank you so much, Mr. Dagoy, for your thoughtful analysis on the issues facing our health workforce. Your work highlights the urgent need for comprehensive solutions to support our frontline health workers. We now turn our attention to the last building block, the health information systems. Our last presenter has been working in public health policy for over 4 years with a focus on health systems and health information systems. His work at PIDS, it revolves around data management and policy research. He has a bachelor's in physics from the Ateneo de Manila University. Let us hear the insights of Mr. Jamel John Anthony Wong.
Hello. I will be presenting our paper about HIS entitled Strengthening Health Information Systems. Next slide. So this is the topic, this is the outline of the presentation. So first, I'll establish a baseline understanding about what HIS is. Then I'll talk about the study objectives, study framework, and then the results. And then to finish, I'll use an example of Ang Kwento ni Rosario. So when we talk about HIS, a lot of it is very abstract. So I'm hoping to kind of ground it into maybe a cute case of how it's used. Next slide. So what is HIS? HIS is often synonymous to IT. So for example, BizBox, iClicksys. The allure of technology can obscure the fundamental role of HIS for health policy and healthcare management. In this presentation, we define HIS more as a system for information generation. So it's not specific to technology, but more a set of things that the goal is to produce information. Similar to any system, it involves the interoperation of several components. It is, of course, IT is, of course, an important component, but so are things like workforce, financing, and even paper-based systems. As we shall show, issues arise when these components don't work together. Next slide. So at the crux of it, HIS policy and interoperability is about clarifying the flow of data from health events, from communities to decision making. That's true whether we're talking about HIS at the national or local level or even at the facility level. These pathways are determined by components of people, policies, governance, and so on. Next slide. As a tool for decision making, HIS is not and shouldn't be thought of as only for national or local government. HIS is a tool used by different actors in the health sector. Of course, for the regulators like DOH, the big example is disease surveillance. But HIS is also useful for healthcare providers, PhilHealth, and even patients. Providers will be able to summarize all patient records and produce analytics that help them provide better care. PhilHealth will be able to get better data and produce better costed benefits, for example. Patients stand to receive better care when doctors have a more comprehensive view of the patient's history. All these aspects of HIS work together to produce better population health. This assessment and its results is structured according to this basic framework: process, people, product. Process pertains to those enabling components such as financing, organization, enabling laws. People pertain to those who operate and manage the HIS. Product pertains to the various aspects of data that the HIS produces, so including standards, the data itself, the reports. This framework is by no means comprehensive, but it allows the results to be presented in a general way that can be better appreciated by everyone. Hence also the motivation for the story in the end. So I won't dwell on this, but this is the objectives of the study. So we wanted to assess the current state of HIS and develop a comprehensive data collection and analytical monitoring and evaluation framework. So we wanted to see what an ideal HIS should look like. Next slide. Yeah, so the presentation is an amalgamation of 3 different studies that performed different methodologies. So we hope that this makes the results more robust, paint a more robust picture about the state of HIS in the country. We performed a review of DOH and federal policies and found that there is a long-standing interest for HIS. Actually, there is no shortage of policies even before UHC. Even before UHC that recognize the importance of HIS and attempt to make its potential very real. However, we found also that a lot of these potential were not realized due to lack of synergy and coordination. So if you notice, some of the issuances, they date back to before UHC. Yeah. So in the DOH, there are 3 primary offices that have something to do with HIS. So this is EB, DPCB, and KMITS. A lot of examples show that the governance between EB, DPCB, and KMITS is actually ambiguous and vague in relation to HIS. Take, for example, malaria. In EB, there are 2 different areas of work that collect malaria incidents. So there's the surveillance, and then there's the FHSIS, which is also separate from the system of DPCB for malaria called OLMIS. And this is just one example of how fragmented things can be. Next slide. So this vague governance has led to so many siloed systems that rarely reach full implementation. You don't need to see the list, but the blue rows are the systems that are commonly used by the sampled RHU. So we have an N of 113. So this is FHSIS, ITIS, the TB system, and then PIDSER, the disease surveillance. And then the orange ones are the systems that are used by a lot of them. The orange row shows the systems that with higher than 30% utilization, so 30, 50%. And those that are on red are systems that have less than 5 utilization, meaning of the sampled 113, less than 5% of them actually use those systems. So viewed as an information generation tool, what kind of information can we expect from systems? The systems used by very few healthcare facilities. Next slide. This fragmentation is also driven by the unreliability of these systems. For example, in iClinicSys, iClinicSys was an attempt of the DOH at integration. So some of the modules of the programmatic systems were put into iClinicSys as an attempt to reduce the systems. However, the experience of RHUs is such that they receive insufficient IT support and that the system is frequently offline. RHUs fall back on either paper-based systems or other systems that they find better to use. And this includes private EMRs. This observation was found across 128 RHUs across 8 provinces. Next slide. The ambiguous governance arrangement is reflected in how finances are allocated. We find that although HIS-related spending on software and hardware has increased, according to the National Health Accounts, paradoxically, the budget allocated for KMITs has been decreasing. So this is an interesting conundrum. The entire health sector is investing on HIS, but the technical unit in DOH for HIS is getting smaller. As a consequence, the technical support delivered by the DOH for HIS is simply not enough. We find that among 22 healthcare facilities in Bataan, the majority of them only receive training for DOH-owned systems at the start of their employment. So once the training has been given, yun na yun. Some of the testimonials are we don't receive any training for HIS, or that their co-nurses were the ones that trained them. Next slide. This lack of training is made worse by basic lack of workforce. For Bataan, we found that most staff are reluctant to use their HIS for various compounding reasons related to training, familiarity with technology, and reliability. In practice, people fall back on paper-based systems, rendering expensive electronic systems that the government has spent on quite unnecessary. Next slide. Additionally, the training of RHUs the training that they do receive tend to favor basic data entry skills. Among the 22 facilities in Bataan, you can see that so the figure is on comfortableness of the staff to perform those skills: data entry, report generation, analysis, claim submission, troubleshooting. You can see that basic operations such as data entry and report generation rank high in confidence levels, while more advanced skills such as data analysis and troubleshooting become more uncomfortable for the surveyed staff. So, and this goes back to the question of for who and for what is the HIS for? A lot of effort so far is put into the interest of the national government, which focuses on data collection. But we also want to see LGUs and healthcare facilities take control of their own data and use it to improve service delivery. Next slide. So to summarize so far, we found that the governance arrangement at least at the national level is ambiguous. This has led to a serious number of fragmented systems that very few facilities actually use. All this is in the context of KMITs receiving less and less funding. This lack of capacity on the part of KMITs renders them unable to provide the technical support that the system users need to actually use the already numerous systems. So we found that while technical policies exist, which is the first few slides, that aim to reduce system fragmentation and achieve a system interoperability, the policies themselves can be technically flawed. Here we compare the data standardization policies between DOH and PhilHealth e-claims. So this is the DOH part, that's the PhilHealth part. In the DOH standard, the variables do not follow conventional technological convention. So for anybody that's ever used Stata, Python, R, whatever programming language, it's the first thing you learn is variable names don't have spaces, and that variables have data types. So that's programming 101. The way the DOH standard data standard was defined is that it was meant almost to be read by people, not by computers. So compare that to the PhilHealth part, which contains a file structure. So they use XML. So for anyone who has also used claims data, they define it as a string, and they use a very compact variable name for the PhilHealth ID, something called PIN. And so to a human reader, these will map to the same thing because human understanding enables us to parse gray areas of communication. But to a computer, these are two different things. In the end, the data standard of the DOH is unimplementable. And as we know, this doesn't have to be the case. This really doesn't have to be the case because the PhilHealth e-claim standard is actually working well. All the hospitals use it. Next slide. And then here, we visualize what it means for healthcare facilities to prefer paper-based systems. The blue line refers to the data generated by FHSIS, which is a paper-based system for service delivery, while the orange line refers to the records in NARIS, the electronic system for rabies, and ICNCDRS, which is the electronic system for non-communicable diseases. As you can see, almost no records actually exist in the electronic systems. As a tool for information generation, what can we do with electronic systems that few facilities use and contains comparatively no data? So this is not strictly a result in the sense that we did not survey for it, but this is based on the lit review. When comparing public health monitoring in different countries, we find that more advanced health systems now use healthcare quality to monitor public health. So it's not anymore the same way as FHSIS that we count service tallies, we monitor healthcare quality. This is only a snippet of what is in the report, but we put it in to make the point that we can do HIS and M&E differently in the country. Some of these indicators we actually presently collect, such as cancer screening and the use of EMRs. However, a lot of these measures do rely on patient-level data. So in the sense, strengthening the HIS is not just about collecting indicators, but also for electronic, interoperable patient-level data is necessary to improve public health monitoring. Things like the NHDR, the National Health Data Repository, can play a really big role in this. So second to the last. So this is just the recommendations for the paper. So we just grouped it according to one. We have to resolve the ambiguity in governance. So we have to clarify the role of KMITs as a technical support provider and regulator, and for PhilHealth to see its role in the HIS so in a lot of advanced health systems, pay for data, for example, is a big thing. Claims data is the basis for a lot of analysis, etc. We have to realize interoperability. We have to have a health standard that is actually implementable. And we have to empower subnational units and even facilities to use the data for themselves. That's it. So finally, I wanted to motivate the results by having a story about a certain Rosario. So Rosario lives in Catanawan. It's a municipality up in Quezon. She's registered to a consulta provider. Rosario has diabetes, so she regularly goes to her consulta provider. Although Catanawan has internet access, they have intermittent power outages. So in effect, the facilities try not to use the system because when it's down, it's down. Then one day, Catanawan was hit by a typhoon. The RHU was damaged by rain and shallow flooding. All the records were damaged. Next slide. So the consulta provider was not able to claim a portion of the capitation due to loss of records. So as a consequence, they had to reluctantly ration service provision until next year, until the next capitation kicks in. So Rosario is not anymore able to receive her diabetes medication for free. She has to go to Lucena City, which is 2 hours away, and pay for out-of-pocket prescription. Then eventually, the added financial burden after the typhoon made it difficult for Rosario to maintain her health. She is not able to fill her prescription regularly. Her diabetes worsens, and then she got an injury that would not heal. So all this, so when we reduce HIS to technology, really, so in this scenario, her conundrum could be solved by one, not only just by digitization, which involves having something as basic as electricity so that the facility can use the computer, but also for the EMR to be interoperable with the other systems so that they can transmit their healthcare records for capitation in a timely manner. So it's not about simply doling out a computer with the software. It's about providing the suite of things that ensure that services are delivered end to end. That's it.
So, thank you so much, Mr. Wong, for shedding light on the challenges and opportunities in improving our local health information systems. His recommendations, creatively illustrated through Ang Kwento ni Rosario, will be instrumental in guiding future policy and digital health reforms. So now we will proceed to our final panel discussion for the day. And again, through this section, our panelists will reflect and react on the previous presentations and share their insights according to their respective experiences and expertise. So, if we can, yes, as they are positioning the seats of honor once again, may I kindly request our panelists to proceed on stage as I call your name. So our first panelist is one of the Philippines' leading public health practitioners. He was the Secretary of Health from 2001 to 2005, where under his leadership, the Department of Health was recognized as one of the country's top-performing government agencies, most notably during the battle against SARS in 2003. By 2026, his public health career will span 50 years, having served in government, the NGO sector, the private sector, WHO, and academia, where he continues to do research on the implementation of universal healthcare. So let's give a warm round of applause to the current chairperson of the philanthropic Zwelig Family Foundation, Dr. Manuel Dairit. Our second panelist serves as an advisor to the People's Budget Coalition, a group of more than 10 civil society groups advocating for more inclusive public budgeting. From 2012 to 2016, he has served in the Department of Finance in roles covering tax, customs, local finance, budget, economic policy and strategy, and the leadership transition. He has been recognized locally, nationally, and globally, most recently as one of the Outstanding Young Men of the Philippines in 2023, as an honoree for socio-civic and voluntary leadership. He now leads the We Solve Foundation as president, where he empowers communities towards systems change in the Philippines. I gladly welcome Mr. Kenneth Isaiah Ibasco Abante. Our third panelist began her career as a rural health physician in Marikina City. Having risen through the ranks in the public health sector, she gained mastery of the system. As the Undersecretary for Operations during the COVID-19 pandemic, she managed to steer the bigger fold of the UHC narrative by vaccinating the homeless, visiting and providing medical care to indigenous peoples, launching primary care. And for her reassuring guiding figure, she was recognized with the distinct honor of the Order of Lapu-Lapu by the Office of the President, Malacanang. She was subsequently appointed as the Department of Health Officer in charge in 2022 until 2023. Let's give a warm round of applause for Dr. Maria Rosario Singh. To complete our lineup, our last panelist received her PhD in medicine from the Wonkwang University in Iksan, South Korea. Since then, she served as a research professor in various universities in Korea, including her alma mater, Kyunghee University, and Gachon University. She eventually transitioned to work on health systems development through her involvement in various regional offices of the World Health Organization, culminating in her present role as the coordinator and lead of the Health Systems Strengthening Team of WHO Philippines. I am honored to announce Dr. Yu Lee Park. And for this section, I will serve as the panel discussions moderator. Good afternoon. I forgot to introduce myself. I am Chanel Mirafuentes, technical specialist from the PIDS Health Economics and Finance program. So I'm very much honored to facilitate our discussion today. So I suppose if I may start with Dr. Singh, we've seen that in Ms. Tomas's presentation on the HFEP, right? So we've seen that there is a scarcity of health facilities, especially in poor provinces. And HFEP was intended as a national grant that was intended to be instrumental to address this gap. So I suppose how do you suggest that we better streamline the HFEP allocation given the political and economic context to ensure that the promise of equity in the supply side is achieved? Quite a loaded question to start us off. Maybe, sorry, let me,
Hello. Yep. Good afternoon to all of you. Of course, good afternoon to our PIDS President, Dr. Tuaño. Magandang hapon po to all of our colleagues here and our experts and my co-panelists. I think I'm so disadvantaged, Sec, kasi I'm the first one to answer, tas highly political pa yung question ko. Baka ma-double termination. But anyway, off the record. Wala bang ganon? But anyway, I just like to say that I think first, before I give my comments, I just like to say that the government has done progress through the years with our health facilities. As you have seen the presentation, it has been 15 years already that we had been investing in our health facilities. And we can see that there has been improvements. But it was right now, as you may see our improvements, it's quite patchy. There are still a lot of inequities. I have seen most of the facilities in the country since I became OIC in 2022, and even during after that, I was able to go around, especially in the far-flung areas. And we can really see the underinvestment in our healthcare facilities, especially in the far-flung areas. One of the things that I would like to say would be DOH has been struggling to focus specifically on these standards that we like to implement so that we can have this kind of insulated process in our allocation of these funds for health facilities. The intent is there. The goals are there, and we really want equity in this kind of allocation, the rational allocation. Unfortunately, I think it is really part of the process already, or our environment, these political factors that we have right now. So I just like to say and tell all of you my experience. So if you will allow, I've been to a lot of areas. First, my comment would be the indicators for our health facilities has all, especially our hospitals, has been mainly focused on adding beds and adding beds, the bed to population ratio, not looking at the entirety of what should be and what we should have in our areas. So we would like to have, for example, this target of 2.7% per how many population, but not realizing that sometimes it is not adding beds that we need, but just supplementing whatever we have through lower level facilities maybe, or just, creating that integration within that area. So we saw that kind of experience when we were doing these bukas centers of the current administration. Ever wonder why these bukas centers were conceptualized? It's because of the lack of or the gap in access of our people, because health centers are open 8 to 5, Monday to Friday. So pagdating ng alas 5, we don't have any facility to go to anymore. So what happens would be our people will go to the emergency rooms of tertiary hospitals maybe, and then they will have their consultations there, even in the wee hours of the morning if their child has fever or, just simply colds. They will go to the ER and they burden our tertiary hospitals. So the idea of having bukas centers was really, I think, very important. It was critical. It's something that can really address the gap in our integration or our network of facilities. Unfortunately, again, the intensive campaign and the hype has gone down already. The first year it was, all LGUs were interested. Now the hype is low already. Na there we cannot it was not sustained. The hype was not sustained, and therefore some of the areas which really needed this kind of facilities were left again without any. Second, I just like to say that aside from the indicators, I would like to say that the budgeting process for our hospitals is very skewed. It's skewed towards our bigger hospitals. I had been harping on this since I headed the operations in the department for Northern and Central Luzon. We all know that Northern Luzon, we have the far-flung areas in the Cordilleras, in Cagayan. And I've noticed that every year, I would see that our smaller hospitals would receive very meager budget. And then they would It's just, the first quarter, second quarter of the year, they were already requesting from me to ask from DOH to give them additional funds because the funds that they received was very meager already. But you would see that our bigger hospitals, which are really self-sustaining already, are still receiving the same huge budgets from our national government. I think the process of budgeting is really skewed because we ask them for what do you need, and they would give you sky's the limit budget proposals, and then it will come back to them that they were only approved for just 10% of what they were asking. So no flexibility at all, no additional funds for them compared to our bigger hospitals who can already sustain their operations on their own. Dr. Ivy, it's not against you. I would really like to, improve all of the bigger hospitals, but I just feel for our smaller hospitals because it should be part of what we are doing, improving our lower level hospitals to become also the tertiary hospitals that we have right now. The next comment that I would like to have, 15 years of health facility funds, investments, 190 billion. But how come until now, Region 4B, Caraga, BARM still do not have tertiary hospitals? So what happened to us? I'd been visiting Region 4B, Mimaropa. During my time, I usually went back there because of a lot of issues then, oil spill and all. And you would see the helplessness of people just for them to have blood transfused for their patients. The blood has to travel from the province going to Batangas and then going back to them. So just imagine, no life-saving measure there. You will wait for how many days before a blood can be transfused to a patient? That's just an example. So I think that's a very big question that we'd like to ask government now. For 15 years, we have had this kind of money. How come these regions until now do not have this appropriate hospital for our population? And the last that I would just like to comment and point, this is, I think, very critical. I've gone around the country. I can tell you 2 out of 4 or 1 out of 2 among the barangay health stations that has been built are closed when I go there. What is the rationale of having barangay health stations in all of our barangays when we just keep them closed? Are we supposed to just integrate the funds and create a super health center? I don't know. But this waste of funds because our budgeting process and our planning process are not grounded. You see, our policymakers, they sit in the DOH central office. So our Philippine Health Facility Development Plan has been planned and drafted inside an office. We need more people who are grounded, who can contribute to this kind of plans so that it becomes more rational, it becomes more usable, and it becomes more, worthy of being implemented. So the Philippine Health Facility Development Plan that we have right now was supposed to insulate our health facilities enhancement program funds from all of these influences outside of the sector. Unfortunately, the PHFDP, though it's there, 2020 to 2040, is outdated. No? So I've reviewed it when I headed the cluster. The data that has been used for that would be 2018 data, I think. And it has to be revised and updated, and I think they're doing it already. But I think there are still a lot of funds that has been poured in already using this kind of plan. So maybe better in the next couple of cycles of planning and budgeting, this kind of policy should be timely updated so that our funds won't be wasted. So I'll stop there. I've said a lot. I will be, if I may have time later on, maybe I can again comment on the recommendations of our good researcher. Thank you.
Thank you so much, Dr. Singh. So I appreciate and I'd like to note your emphasis on the integration of not just our facilities, but also, I suppose, its relation to the other building blocks of health that are also facing its own inequities. So on that note, if I may direct the next question to Dr. Dairit, So similar to HFEP, we also have national HR deployment grants to augment the inequalities or maldistribution in the healthcare workforce. So how do you suppose we can better align these grants or augmentation with capital investment grants and reduce the silos across the program?
Maybe Rosette should also answer that question. Okay. Maybe I might just preface my statement by saying, if you recall in 2015, USAID came out with a report that over the last 25 years, after devolution, our health outcomes didn't really move. And one example for that was maternal mortality rate. It was stagnant for 25, 30 years. Okay, that was 2015. 2015 to now is 10 years. And what we're hearing is that the government spending has actually far increased. And you heard all of the presentations. Okay. And that brings up the point, no? How well was that money spent? Okay, I know that Oscar Picasso, sometime in 2013, actually visited some of the HFEP facilities and said that the construction was miserable. That even if local governments were given the money, they did not use it very well. So I think that's one issue we have to flag. We're increasing government spending, but we are not really using the money well. Now, to your question then of HFEP funding coupled with local governments and HRH, I think the general answer there is you have to have better governance that breaks the silos between those who are doing the CapEx planning and those that are doing the health deployment as well as HR planning. And I speak to you here not as an ex-Secretary of Health, because as chairman of Zwellig, I've been able to go around the LGUs. And as a teacher in Ateneo, just yesterday, I was talking about health system building blocks. And there was one word that really captures all of this. It's what you keep saying. It's fragmented. And so the question is, how do you actually improve governance across silos? And if you think about how our government works, and I was here, I'll put my hat as a cabinet minister. The line agencies work silos. They work in silos. So what has to happen is there has to be a whole change in the mindset for the organizational culture across government and the design of organizational mechanisms. I think that's really what has to happen. And when I say organizational cultures, this means that really across different sectors, you have to work together. And this is so important when you're talking about capital expenditure and human resources. And I'll end by saying, because I've also been exposed to private sector, and many private sector companies are actually expanding within healthcare. They really plan so that when they build their hospitals, they're already planning for the equipment that's going to go there and for the staffing that's going to work there. In government, it's still the same. Since I was a RHPP, as they call it, that's the precursor of the DTTB, and I was in Davao del Norte. In the municipality where I was working in, there was a World Bank funded rural health unit that didn't have any equipment and didn't have any staff. So I think that's the answer. You have to improve governance across the board, but that means changing organizational culture across government and really identify better organizational design. Thank you.
Thank you so much, Dr. Dayer. So I think this was also mentioned in the earlier panel, like something about a paradigm shift. We really need to employ a paradigm shift, but I suppose on a much larger scale. So now going back to like perhaps one of the ways in which we can improve these cross-sectoral and multi-level collaborations is through the empowerment of our stakeholders through access in data. So another one of the silos that we have to break. So if I may address this question to Mr. Abante, given your work and experience in data governance and empowerment through information. So data availability and transparency are critical for improving any national program. So whether that's for PhilHealth, capital investment grants, and the like. So of course, as highlighted a while ago, we have to ensure that these programs are efficient, effective, and equitably allocated. So given the current state of the programs and how we're going about things, what do you think is preventing the health sector from making stronger progress on this front, especially from a health information or data perspective?
Thank you so much. At magandang hapon po. Good afternoon, everyone. I made an instant presentation a while ago because I was so inspired by the researchers. I wonder if pwede niyo pong ma-share. I think the first point I wanted to raise about progress, if you could go to the next slide, please. If our nation is a body, then corruption is like cancer that has spread through many parts. And what we must do is to acknowledge we have the illness and decide to act on it. The first thing we must admit and we must know is that there is this massive cancer that we have to surgically remove. Thankfully, the Senate has made welcome shifts. 260 billion pesos in pork that we tagged has now been reduced to 110 billion in the Senate version, including MAIFIP. The Senate reduced the MAIFIP by 25 billion back to the original National Expenditure Program proposal at 24.2 billion. The Senate has also cut by 77 billion pesos the risky infrastructure line items we are monitoring, including some health facilities, but mostly road and bridge programs in the DPWH and flood control programs. But several concerns still remain. According to my idols in the Healthcare Professionals Alliance Against COVID-19, the Senate version still has shortfalls in the PhilHealth budget that was due the Universal Healthcare Law. Only 50 billion was returned from the budget that was swept by the Department of Finance last year from the PhilHealth. We now have 113 billion in the Senate version, but 146 billion is the legitimate funding requirement for 2026. And there's a cumulative deficit of 255 billion since 2023. And this is a cancer that has also spread. It is not just the Department of Health that is experiencing this type of cancerous growth in pork. Everywhere, in many agencies, there is a parallel pork structure that has grown. In the Department of Social Welfare and Development, that's AICS and ACAP, as opposed to the cuts in 4Ps. In the Department of Health, we know that it's MAIFIP versus the rules-based and rights-based program called PhilHealth. In the Commission on Higher Education, there's also a parallel pork structure. It's supposed to be universal college, right? But there's now a line item called the CHED Tulong Dunong. That is a 2 billion peso program that is still already a large tumor, but really maybe a stage 1 cancer, if we allow that to happen, none of the well-planned national expenditure program plans in the budget will have space. And we will not have properly planned programs, especially in the health facilities enhancement program. Next slide, please. If you go to some of our transparency portals called budget.bettergov.ph, we computed the congressional insertions to the Department of Health budget to be around 130 billion from 2020 to 2025, mostly in MAIFIP and the Health Facilities Enhancement Program. Next slide. You can check the line items here. Here's the HFEP. Here's the MAIFIP. Laki, no? And lastly, we now have the tools to be able to check these projects. With PhilJeps and the procurement service DBM, we have proactively disclosed 5 million awarded contracts worth 15 trillion pesos from the year 2000 to 2025 that journalists, citizen monitors can use in order to check the status of many of these awarded contracts. You can search your locality, check the word hospital, and it will be there. Or check Camarines Sur, check Region 4, and see what contracts have been awarded. So maybe that's the first one. This information that we all have to play our part to make sure we remove this cancer from the 2026 national budget. We're making progress, but there's still a lot of pork. Okay? Kaya po ba yun? Yes? Yes. Okay. Kakayanin po natin. Basta tulong-tulong po tayo. The second action item that I wanted to ask for empowerment is I was so impressed with all the policy research that you've done. Great job, PIDS. Is there a way we can work together to practice what we call data for empowerment in co-creating a mayor or governor's outcomes-based budgeting platform for health? The parallel lesson that I want to share with you was our experience proactively disclosing the learning outcomes of the Department of Education. So this was released just a month ago. This was the first time learning outcomes were released proactively across 5 different regions. And the important ratios and backlogs across every school is now published for any mayor or governor to check. But as Dr. Dairit mentioned, sorry, next slide. That's next slide. Ayan. But as Dr. Dairit mentioned, it has to be all in one place. No? So part of the reason why policy is fragmented is because local chief executives don't have all their information all in one place that tells the story that they need to act on. So one example is when we consulted the people who would use this data, because we didn't just release it, we designed it with the people who were going to use that data. They said, can we please include the classroom backlog data here? So this is Camarines Sur National High School with a 90+ classroom backlog. We used this in our local school board meeting in Naga City. We also put the MOOE budget, and we also put the learning outcomes data. And so part of what was discussed in our local school board in Naga City was 1/3 of our special education fund was spent for classroom construction. But our learning outcomes are still very low. So we need to put more investment in teacher training. We need to work with the Department of Education National to bring these classrooms down. And then we trained the Naga City People's Council on what we call outcomes-based budgeting deliberations. So there's an 8R framework to ask the right questions when it comes to budgeting. I can share this paper with you. And then finally, please, let's work together to monitor projects on the ground with the church. We have a partnership with the Catholic Bishops' Conference of the Philippines to monitor the flood control projects. So we have a volunteer portal with the church and with the Mayors for Good Governance and Tapat, a civil society group, where dioceses can go to certain projects, and we have a certain checklist for quality checking the monitors. So we have to work together in order to do this. If our nation is a body, again, we must admit that we have this cancer. We have to act on it. But we as civil society, as researchers, as monitors, are the antibodies that will help ensure that we recover from this disease. I remember, just to close, during COVID-19, Yusek Rosette was the calming voice that I heard when we were panicking about the COVID-19 spikes. And I recall when they released the COVID-19 dashboards, we worked with our Health Emergency Response Task Force to work on the data that was being shared by Yusek Rosette on TV and to be able to lower the positivity rate in our hospitals and in our communities. And we were able to lower that from 30% to 8% through the proper communication and storytelling, and really the really good dashboard that we had in COVID-19, because it was clear what our outcomes were. So we can learn also, not just from other countries, but from a lot of good case studies that we have here at home. And we don't need to look far. We've already done it. And I think we can do it if we work together and we can recover from this illness, from this cancer that ails our society. Thank you
so much, Mr. Abante. Now, given the ills outlined, the challenges as well as potential cures, it's good to, I suppose, it's reassuring that, as you've said, there are actually local case studies already that we can apply. But also, I suppose, to give us more hope or something that we can look forward to. I now direct the next question to Dr. Park. With regard to other countries' experiences. So for in many other countries, consolidating fragmented public financing pools has been the centerpiece of health reform. So for our country, in the Philippines, the UHC Act actually aims to pursue the same direction. So given this, what political and operational challenges did these other countries face? And how were they able to hopefully successfully navigate them?
Thank you very much. And first of all, I would like to acknowledge this great achievement presented by PIDS, the researchers, which is really impressive, having all this in-depth analysis across all the key health system building blocks. And on the question, so while I'm listening to all this presentation, I would like to go back to the first presentation today afternoon. Sorry that I missed the first in the morning session, but the financing is, yes, as you mentioned, is a core element of many health system reforms across many countries, because this is really driving factor, change the service delivery design and healthcare providers' behavior and health seeking behavior by communities. So that's why many countries are looking at the financing reform as a driver to achieve universal health coverage. And here, but I would like to go back to the three key components of a health financing from WHO perspective. One, revenue generation, revenue raising. The second, pooling funding. And third, strategic purchasing, specifically purchasing. Then why we are doing pooling? This is a really fundamental question we need to reflect, because we are pooling funding. At all your presentation, there are two main components. One, risk pooling. We really try to risk the cross poor and rich, healthy and unhealthy population, risk sharing. The second is to avoid, as we discussed, to improve efficiency across a fragmented system. So that's why many countries are looking at this pooling. But at the end of the day, with this pooled funding, they want to do strategic purchasing. Then that's where we can link all these discussions, starting from facility, human resource for health, and data. Without this enabling system to run health system, what do we want to buy from providers? This is really enabling factors and foundation for the government to purchase, and specifically using data. how they can do purchasing strategically while they are increasing, but using their limited resources more efficiently. This many countries were looking at to achieve universal health coverage, which is defined to ensuring every person in any country to have equitable access to quality healthcare services without financial hardship. So this is many countries did. And with the discussion then in this world, whether there are really good examples, unfortunately, there is no easy answer to the question because each country is navigating their own system and they are going through their own journey in their own context, situation, and resources. So from that perspective, I would like to go back to the governance issue. Why countries then starting this pooling or looking at health financing? It is usually coming from political commitment. In the context of political economy, because when you change any system, there are a lot of dynamics you need to manage. I will use the example of Thailand. When Thailand introduced the Universal Coverage Scheme, UCS, at the beginning of 2000, can you imagine? The Ministry of Public Health, they were usually main purchaser and they are usually the supply all these health system building blocks investment. Now with the new creation of National Health Security Office and then changing and pulling all the funding through that single purchaser, you can imagine how this was shaking the system. So this is really how the system should be, whatever reform you take, you need to navigate. And in this process, now with this new introduction of UCS and also 2 additional schemes covering the government officials and also private sectors through social health insurance scheme, the Thailand government could achieve almost 100% coverage of the population in terms of service delivery and financial protection. Still, there is ongoing discussion how to navigate this governance issue, how to seamlessly between National Health Security Office and Ministry of Public Health work together in a coordinated manner, not to duplicate their investment, but or more maximize their limited resources. However, in this context, what Thailand was highlighted at the global context is their major investment, substantial investment for healthcare facilities at the primary care level. I think I'm going back to the second, the first in the panelist comments. This where, because when the government pull all the funding through single purchaser, when the government has a lot of investment to ensure all the primary care facilities meeting certain standards set by the government, then you can do really strategic purchasing because you have certain level of quality ensured across all these primary care facilities. And the second, what they did, human resource for health. They invested on human resource for health. Who's gonna run these new fancy hospitals? And then when we look at this, some of the success, which is still ongoing in Thailand, while they're also tackling a lot of challenges, their investment on primary healthcare, going with pooled funding through single purchaser, is really leading to the current sort of success and progress. Again, I'm not saying this is really perfect example because they have also their own struggles and challenges. And the second example, which I would like to share very briefly, is Mongolia. Mongolia's case was quite interesting. Again, ongoing journey. So, but the reason why WHO is looking at Mongolia is a very interesting case. They use COVID-19 as a momentum to register all healthcare providers because there is that's what I meant at the beginning, governance and political economy, because they are looking at entry points and momentums and they grab COVID-19 to register all the providers because there are a lot of investment through the government and other multiple sources. And then second, Ministry of Finance requests the health to improve efficiency because the funding was so fragmented through different channels. So with this pressure and external factors used as momentum, they created now single purchaser, which is named as Health Insurance General Agency, Hagag. And through this single purchaser, now they really pulling all this funding, either government funding and the contribution, because it is a social health insurance scheme. They are trying to purchase with again, strategically using different provider payment mechanism as you discussed in the morning, whether DRG or mixed the provider payment mechanism to really influence, and especially with a strong focus on primary healthcare financing. However, even in this Mongolian context, again, as I shared, they are going through ongoing journey. So that's why they are reviewing their performance indicators, how to pay for primary care facilities and providers, and also how to capture, especially this Mongolia has a quite smaller size of population compared to Philippines, as an example, like a less than 4 million population, but still they have a lot of nomadic population who are often left behind. So from their perspective, that is also their key priorities. When they try to achieve and address all the health outcomes left behind, without addressing those left behind, they cannot achieve. And I think this is the same situation in the Philippines. That's why we discuss JIDA and how we can really reach out those left behind in the context of the Philippines. Same situation in the Mongolia, even though they are doing this all strategic purchasing through one single purchaser now, they are also going through all these challenges to really overcome some of the governance issue, because still they also have a lot of governance issue. They need to overcome their governance issue. It's a bit slightly different from others because they also have quite high turnover of the senior management, is the top management of ministry and also other levels of the management in the ministries. So I think this is sort of two examples to share with you. And just wrapping up, I think the pooling of funding sources, again, I'm going back to the fundamental reason why we are doing this. It is first, equity, second, efficiency, and at the end of the day, strategic purchasing to improve quality healthcare services. And I would be very happy to share more comments as needed. Thank you.
Thank you so much, Dr. Park. And again, thank you so much to the insights of our panelists. So I think we have time to entertain a question or two from the floor. So in the true spirit of collaboration from our different stakeholders. So if you have any questions from our esteemed panelists, please raise your hand and then we can maybe...
Thank you very much. First of all, I'm Dr. Tessa Tantor-Sedeja, formerly from WHO in Geneva, in health financing. I think I'd like to congratulate the work of this program. In such short period of time, you have been able to do a lot. But I think we all know a lot more has to be done. I think this is the first pass of that billions and billions of data bits that you have. And I think there is a lot more data, a lot more information that we can get from there. But I think I would like to make 2 points. I will ask one question, but because it will be loaded, I won't expect an answer. And then the second one is a suggestion. We ended the morning session talking about the elephant in the room, about the professional fees of doctors and how actually should we try to think about that within the DRGs that we are trying to put together. And then somewhere in the presentation on human resources, there was one line there which was very telling, but hindi yata binanggit talaga, which was, should we move from the non-differential funding of reimbursements of private sector from the public sector? And that is a big question, because basically, I think this has been pointed out in terms of the financing flows, that public and private facilities receive the same reimbursements, but public facilities receive government funds or subsidies for salaries and maintenance and operations, including capital investments. I think that's inefficient and unfair. And therefore, that could be part of a bigger discussion and not just on professional fees. So I think that's a political question and it's loaded. And I think it's not yet circulating in the awareness, particularly of the medical community. But I think it's something that needs to be considered. The second part is, and this is a question to PIDS, I'm so sorry, not really to the panelists, but maybe you can contribute your opinion. Whenever we talk about HRH and facilities, I sometimes wonder how well do we actually know the situation? Or the more specific question is, how well do we know and incorporate in our analysis the private sector? Where is our data? Hanggang ngayon pa ba, ganon pa rin ang tanong. Ilan ba talagang nurses, private practitioners, hospital beds, facilities, the hole-in-the-wall doctors? I think we've stayed with this constraint for such a long time. Whose accountability is it to actually collect that information so that we can start planning for the health system as a health system, not just the public side? Thank you.
Would
It's difficult to tell.
I'm so glad you raised that question, Tess. I'm now on the spot. No, but on the question as to whose accountability it is our accountability. That's the first thing that we have to make clear. Earlier when during the discussion, we had a huddle. All the division chiefs of HHRDB are here. So we had a huddle, and we even had a huddle with OSEC. And we said, this is something that's going to be very challenging, but it is something that we have to do. So hindi pwedeng mag-excuse na walang tao or hindi amin yan. It's something that we have to pursue. So that's the first question. Amin po yun, DOH at the very least, pero HHRDB yun. We have, just as an update, we have started that conversation. So it's not been reported, but we have started 3 years ago to reach out to PMA, to PCP. We have maintained good relationships with them. Even the Secretary of Health has requested for that meeting, where you remember that Doc Casey, and it is challenging. That's all I can say for now. But we're pursuing this road. It is something that we have to push. Again, there's so many things that needs to be done. So many things to be done, and given our resource constraints, our question always has to do with, so which of these interventions do we invest in? Which ones will have the most impact to the health workforce? And so some of the more strategic things that are really needed to be done get left behind. That's where we are at this point. But I'm very thankful for what has come out of this conversation. We actually approached PIDS before and asked for help to sort of untangle the little messes that we found. When we finally laid out what needed to be done, 1, 2, 3, 4, 5 in the next 3 years, sabi ni Val, Ma'am Jo, ang gusto mong pagawa ay 20 years. 20 years. Pero we have started doing it slowly. So ang battle cry is, sige lang, hinay-hinay, apan kanunay. Thank you po. Thank you.
Thank you so much, Director Van. Also, Dr. Well noted on the question posed to PIDS, and we will make sure that that is something that we take into consideration as we plan and we collaborate with our stakeholders on providing technical assistance wherever it's needed. I suppose for we have time for two more questions from the floor. Or so
Hi, Benjo de Remente, UP School of Economics, College of Medicine. So actually, kay Ma'am Tessa, si Dr. Kraft and I were just agreeing, very amazing comments. Siguro just to sort of follow up in terms of sa private sector knowledge then parang siguro maybe two things. I also mentioned this to other people as well. In terms of like getting knowledge about a comprehensive picture of the private sector like services, like I remember when I was in the States, I used the American Hospital Association has an annual survey with very detailed information. To the point that do you have services on adult heart surgery, PCIs and stuff like that. So I don't know how much of that information is being collected as well at the DOH level. And then like another issue, I'm not sure that's hospital related, that's also not, I don't think at the moment it's being discussed, is sort of a possible, and I say possible because I don't know what's happening, sort of, we're seeing a lot of these hospital groups forming. We come to mind, Metro Pacific Health now has like 34, 35, 36 hospitals. Mount Grace also has a similar number of hospitals. We have other players in the market. And we don't know what the effect is on prices and quality of care. When in the States right now, that's the biggest or one of the biggest issues right now in the States is hospital consolidation and consolidation overall in the market. So siguro may get some thoughts on these issues, particularly in sort of the consolidation issue. If either on when Dr. Verher was in the DOH side, was it already on the radar, or do you have like any sort of anecdotes or anything about what's happening in this space? Thank you.
yes, you like to say something, Dr.
This is
Verher?
really anecdotal, no? Because I'm on the board of AC Health, and also I'm on the board of one of the Mount Grace hospitals. But I think private sector is moving strongly into healthcare, and you can see it, no? But they have different approaches. For example, Ayala is doing an ecological approach. They're doing not only hospitals, but they're doing pharmaceuticals, generics, information systems, et cetera, et cetera. They're building this whole ecology. Okay. The approach of, for example, the Metro Pacific is really more tertiary hospitals. And even Mount Grace is all tertiary hospitals. They don't want to touch primary care because their view is PhilHealth's very, very unreliable and they don't want to touch primary care. But Ayala is willing to gamble on primary care. And in fact, many of their corporate clinics are primary. So for example, I would consider going to an Ayala clinic and register there instead of having a private family physician be my primary physician. Because in a clinic, I have access to all of the physicians who are there, okay, as long as they're accredited both by PhilHealth as a facility and as individuals. But this is what's happening in the private sector. About 2 years ago, we were asked to describe the workings of the private sector in the Philippines in a study that actually included a few countries. And essentially, we were only really able to describe it, and come up, with similar figures that have been mentioned here today. But Tessa's right, no? The UHC law was designed really thinking about a predominantly public system. My understanding is a lot of that was patterned after Thailand and maybe even the UK. And therefore, when you look at the provisions of the UH law, essentially, when they talk about private sector, they just say, oh, do contracting. Okay, but it's really much more than that. And we have a very mixed system, patterned after the US. So really, our models for trying to move universal healthcare, we're really left a lot to our own devices. Okay, we really have to innovate amongst ourselves. Thank you.
Yeah. Just like to supplement Secretary Dairit's response. As in, if I were to go back and look at our situation or how we have dealt this with in the department, for the longest time, as what the Secretary has mentioned, Secretary Dairit, the private sector is not part of the radar, even for data. And we all know that. So for the longest time, DOH has been doing decisions and doing policies with only evidence coming from the public sector. Our main information, source of information would be always the PhilHealth Service Information System, the CEPHSIS. And you only capture data coming from the local governments there. You don't capture data coming from the private sector. Even in our hospitals, we don't have the universe of all of the hospitals here in the country. We only have the number of those who are licensed by DOH. But once you don't go for the licensing and accreditation, we won't be able to capture you anymore. And you can even operate on your own. That's how data is. That's how lacking our data is in the department. Now, as to this consolidation of hospitals, these networks has been built, I think it's part of how the market has been pushed because of all of these inefficiencies and gaps in our healthcare system, borne by the scarcity of resources coming from the government side. So public sector, private sector is coming in. I'm more familiar with what Ayala is doing, as what the Secretary has mentioned. They're more onto the comprehensive side of healthcare, where they look at what a local government may need, whether it be in public health, whether it be the hospital, whether it be in ancillary services, as long as they can help the local government. And I think the other groups also has that kind of intent, just to address the gaps in our health service delivery within the country. So this consolidation have started even way before. It's not just now that they are being well talked about, but this information has been there already with the DOH. Unfortunately, this kind of consolidation does not reach the level or the tables of our decision makers. It is there with our licensing office. We will know that there's a change of name, a change of owner from this to this, but that's it. It stays there, and it's not part of the radar. It's not going to be discussed. And I think that's a good information that we now put on the table, and our DOH officials are here, so that it should be discussed. Now, what is the effect of this kind of consolidation in our health service delivery processes and networks, and especially to the costs and the financing mechanism for the health sector? I'm done already.
Dr. Park would like to respond to the
Not responding to this.
you have your,
Not responding to this very challenging comment, but I would like to. I think it has opened up really new forum on a very important topic, and I would like to. I'm also looking at representative from the Department of Health, because a few weeks ago, even last week, with Dr. KZ, we discussed private sector engagement. Because now with World Bank and WHO, we are preparing UHC forum at the beginning of December next month. And in this forum, several countries will announce and launch health compact. And this health compact, why then we develop this health compact? I asked this question a lot to World Bank, because it was initiated by World Bank, and their main question is how member states want to engage with the private sector now to achieve universal health coverage. So this is not new question. I think this has been there, but I think we cannot really ignore anymore. I think we reached the kind of level. That's why there is more active discussion even within WHO. Because for instance, within this regional office, Western Pacific, we recently collected what are your priorities of countries. Top priority was private sector engagement. It is coming from Mongolia, Cambodia, Laos, Vietnam, China, Philippines, so across many countries. But I just want to share with a couple of points for your further consideration. We will not be able to discuss all the issues. But again, countries are looking at entry points within your own context and momentums given to a certain time when the government tried to take action. And one is regulation. And I discussed with substandard falsified vaccine issue yesterday with the FDA and key stakeholders. And one of the key questions was how to regulate or how to manage all these products, sometimes highly available in the animal biotreatment center, which are not regulated. There is no mandate for them to really be licensed or even certified by Department of Health, but LGU can issue business permit according to the conversation. So I think these kind of issues are really coming up. But when it comes to regulation, the National Regulatory Authority legally should have legal and regulatory power to really sometimes revoke license. If it is not licensed, close down the facilities. That's how many other countries are also looking at, because they're using the government's regulatory power. But there are pros and cons. And that's why we always take balanced approach, because if facilities are not ready to comply, go with this regulatory system, then this system will also see some more challenges. The second point, which we also see is after the pandemic, many countries start to review and devise their public health related act, whether it is a Communicable Disease Act. So why? Because they were struggling with this data, especially data reporting from private sector, from surveillance perspective. So this is one of the key challenges which were faced by many member states. And the second point, with the second sort of actions which we could see observe across many member states, is looking at their Public Health Act or relevant act to really see what is the current legal mandate in force private sector to report. And the third one is related to our discussion. Single purchaser has the kind of power. When all the funding is coming through one single purchaser, I'm looking at my own country, Republic of Korea. As you may know, more than 90% of healthcare facilities are private. So that's why our country was really struggling during the kind of public health emergency. Then how the government can really control or manage this bigger, more than 90% of healthcare facilities owned by private single purchaser, because their majority of revenue is coming from the National Health Insurance Scheme. Of course, in addition to this, there are multiple mechanisms, licensing, registration for healthcare workers, licensing for healthcare provider at the facilities. So not only single intervention, but that's why many countries are also looking at this as because we discuss why single purchase is important, because they have power at scale. And then if the revenue generation is coming from this single purchase of even in the private sector, then the compliance of the private sector is also increasing. Again, depending on country context and situation, there is no single solution which we can really look at. So but I just want to share these are three interventions where many countries are looking at when they discuss private sector engagement. Thank you.
I suppose for our last, since I've been asked to start wrapping up, just to conclude, if Mr. Abante would have any insights on maybe not necessarily health information, but if you've had any experience on how we can engage the private sector into really pushing for data empowerment and more transparency, I suppose, improving access to data.
Thank you so much. I think, a technical solution like a dashboard cannot solve a political problem, which is, the health systems and the social determinants that determine the health outcomes of our country. And it's critical that these information systems are only as good as the communities they empower. And just to be very concrete about this, for example, in the way that we're trying to do outcomes-based budgeting reform now in the Naga City, I'm a member of Mayor Lenny's transition committee in charge of outcomes-based budgeting reform. And one of the things that we're doing is trying to figure out, coming from the local health scorecard, which I think the DOH did a really good job doing, these baseline scorecards. I think one really interesting flip side to that is figuring out how then are local health boards able to decide on these many different pockets, fragmented pockets of revenues that we draw from. And then how can we develop, especially, and have indicators that take a look at what percentage of our local health budget, or including even national budget, our total pie, is for primary preventive care? What percentage is for tertiary curative care? And I think having indicators like that in outcomes-based budgeting allows policymakers a chance to figure out what proportion they should allocate their budgets in. So I've sat in these local health board meetings. I've sat in the COVID-19 Health Emergency Response Task Force. And when we go into these different communities, one of the most underinvested and maybe also even excluded from the process are the barangay health emergency response teams and the barangay health workers and the state of our barangay health centers, sometimes being very, very flooded. So part of these discussions is, part of empowerment is asking who are excluded from the decision-making processes that are actually providing the most vital services in our public health system. Are they included in our pay surveys? What top-up mechanisms can government, city government, and the national government do to support our frontline barangay health workers who are really at risk in the field? We were working with them to try to isolate the COVID-19 cases in our city when the Delta and Omicron surges happened. So again, that's part of the question. And we will only be able to have an uptick of use and people will start taking seriously the reporting if people see the use of this data and if they feel that they are included. Final case study. When I was in the Department of Finance, only 30% of more than 1,700 local treasurers used to report on their statement of receipts and expenditures. Okay? 30%. What we did as a part of our reform was the Secretary of Finance, then Secretary Purisima, wrote a memo to each of these local treasurers saying what the scorecard was, and if they did not have a submission, say that you did not submit. and then they said, these are the observations in your fiscal sustainability scorecard. So we sent all those memos, but it was not just a memo. It was the Secretary of Finance saying, we are trying to look at your reports. It's your duty to submit those reports. We issued another policy, a department order that included these reporting mechanisms as part of their promotion so there were carrots and also sticks. We also professionalized our local treasury system by having the basic competency exam for local treasurers partnered with the Civil Service Commission, so that in a treasurer's, there are 3 levels to this. And then you will only be able to be promoted to a higher class city or municipality or province if you go through these 3 levels of certification. After those reforms, the reporting mechanisms, the reporting compliance went up from 30% to 99.9%. Yeah. And now I'm very thankful that the researchers are now using the data from the Bureau of Local Government Finance, because that is the core of what local finance data is supposed to be. And then finally, there's also this practice called proactive disclosure. The gold standard of the freedom of information movement is if citizens no longer need to request the data that's sleeping in the government servers. Okay? So part of what we're doing with many agencies is creating department orders that will have a proactive release calendar or an advanced release calendar of all the data sets that they should release. Their tables, they're also public use files for researchers. So we don't have to spend days and months cleaning all of these data sets, right? Have a clear data schema, and then release that at proper times with proper use. I think one of the reasons why health outcomes data is very, very difficult is because very, very difficult to manage is because we can still improve the feedback mechanism that we have with the field, right? I'll contrast that with the economic agencies. The economic agencies have inflation data every month. We have GDP data every quarter. We have now poverty statistics more frequently. And so the BSP has consumer confidence surveys very regularly. And so the feedback mechanism and people's expectations that government and economic agencies report on these indicators is already set. You have media beats reporting on it. You have journalists reporting on it. You have researchers building their academic careers on this. And so I'd say there's so much from the DOH data that can still be released to the public in a way that will empower many people so that we have this ecosystem, again, civil society antibodies that will help us achieve this level of trust and achieve these public service outcomes. Thank you.
So thank you so much to our panelists for our very rich discussion. I'm sure that a lot of our audience, as well as personally also, it was really great hearing from your different perspectives and lenses. So if we may invite you for our photo opportunity, and if we may also call our afternoon sessions presenters to the stage so that you could be involved in the photo opportunity. May we also invite to the stage Dr. Tuaño to be with us on stage. So once again, we extend our deepest gratitude to our panel members for sharing their expertise and for contributing meaningfully to our to today's forum. So your participation and everyone else helps move the conversation on UHC forward in significant ways. So if we may request everyone to settle down as we near the closing of our program. So our final speaker has served as the chief of the government's main health workforce bureau, the Health Human Resource Development Bureau. And this bureau enabled her to lead the collaboration between the supply and demand sectors of the health labor market to ensure adequacy, competence, and decent work conditions for the country's health workers. Now, to formally close our program, may we invite Director Johanna Banzon to the stage.
Magandang hapon po sa lahat. So this is the last part. So as we close today's forum, UHC in numbers, I just want to take a moment to reflect on what this day has shown us, not just in terms of data, but in terms of direction, determination, and collective responsibility. As I sat through the presentations today, it just struck me, Val, how critical this forum really is to know, or at the very least to have a sense of where we are in terms of where we want to go vis-a-vis UHC. Actually, ginagawa namin ito sa DOH din. But it really helps that, we get a better sense through all these studies. When the Universal Health Act was passed in 2019, it really represented a very, very powerful promise that every Filipino, regardless of income, location, or circumstance, should have access to affordable quality healthcare. Sa HHRDB, ang sinasabi namin, whether in the highlands or in the islands, 5 years or 6 years later, it is only right that we pause and ask, nasaan na nga ba tayo sa UHC? And today, through the 11 studies presented by PIDS-HEFP and partners, we have been given not only answers, but a bit more clarity of where we are. So the studies we saw today, built from large-scale surveys, administrative data, and careful analysis, gives us a clearer and more honest picture of where we are truly in our UHC journey. From the morning session, it became clear that provider payment reforms aren't just technical tweaks or changes in reimbursement. Hindi lang po ito tungkol sa bayad. These reforms actually shape behavior, incentives, efficiency, and ultimately the quality of care that people feel on the ground, not what we think we're providing them. The quality care has to be experienced. The evidence presented, whether on DRGs, value-based payments, or outpatient benefit reforms, shows that payment reform isn't some distant ideal. It is practical. It's a necessary shift if we are serious about building a modern, responsive health system. This afternoon, our attention turned to the building blocks of UHC: financing, investment, information systems, and yes, our health workforce. They are the foundations of everything we ever hope to achieve. We saw just how fragmented our multi-payers financing system is and how urgently we need coherence, congruence, and stronger strategic purchasing. We saw how smaller health facilities receive lesser support and how some of them are not even functional just because our plans have been developed in silos. We also face the reality that our digital health ecosystem still has major gaps, and it hits very close to home. The need to strengthen our own K-MITs, even as the world moves faster towards digital integration. And of course, we revisited the health workforce, the numbers, distribution, welfare, and compensation, and have seen the disparity between our public and private health workers. The message is clear, though. Walang UHC kung kulang, pagod o hindi naaalagaan ng ating health workers. When we put all these studies together, we get a picture that is both sobering but also hopeful. They remind us that progress doesn't happen automatically. Good intentions are not enough. Real reform requires strong systems, good data, and the political will to follow the evidence, even when the findings are uncomfortable. But there is hope. We now know things that we didn't know before. Yun, isa. We now have tools that we didn't have before. We have rich administrative data sets, nationwide surveys, and stronger analytical capacity. For the first time, we can see the health system with greater accuracy, its strengths, its gaps, and its potentials. Hindi na po tayo nangangapa. We have numbers and evidence that can guide smarter decisions moving forward. As we move forward, the real challenge begins. Ano na ngayon? Ano na ngayon? How do we transform these findings into actionable reforms? How do we ensure that evidence genuinely shapes budgets, regulations, and institutional behavior? How do we build systems that are fairer, more transparent, and more people-centered? The answer lies in what we choose to do after today. Let this forum not be a one-time event, but the start or continuation of a deeper, data-driven commitment to UHC. Let us take accountability for the knowledge that has been passed on to us today. Let us nurture a culture where research informs decisions. Hindi na nga po tayo naghahanap ng gigil. Although maganda din kung meron tayong gigil for data, okay na yung building a culture where evidence is needed and where reforms are continuously monitored and adjusted based on evidence. It's so easy to get distracted by the work that we do. I will say this from the heart. We get drowned in work, but please, we should also remember that behind every data set is a Filipino family making difficult decisions. Behind every indicator is a health worker trying to serve. And behind every statistic is a life we can make better. So on behalf of the organizers, I extend my deepest gratitude to all presenters, panelists, and participants for your insights and engagement. Thank you for giving your expertise, your experiences, and your time to this conversation. The work ahead is challenging, but today has shown us that we have the tools, the knowledge, and the collective will to move forward. As we close, let me return to the question, nasaan na tayo sa UHC? After today, the answer is clearer. We know where we are, and more importantly, we know where we must go. Maraming salamat, PIDS. Maraming salamat din, Randy. Maraming salamat, Val and HEFP team. Mabuhay po kayo. Maraming salamat po sa lahat, and let us continue to build a health system that every Filipino deserves. Magandang hapon po.